to eat there last night, but I've eaten at Rock Eagle probably 500 times during my career as a county agent. So I hope you all enjoyed it, and I appreciate 4-H and UGA putting that on for us last night. It's a place that means a lot to me. It's been I spent many a night there back when it was unair conditioned. And way back in the early 80s, it was a tough place to be, but it was fun. Also for the committee, we'll say it a couple of times, we have lunch for the staff and the committee afterwards, and Holly will tell us where, in a fellowship room somewhere. She'll direct us then. But when we were trying to find things to talk about and that are relevant, I talked to my community service board person, Melanie Dallas, and we got to call out Melanie. If you will look at her feet, she does have her toenails painted, but she had surgery. Just how long ago, Melanie?
Just
last Thursday. She didn't tell me she was going to do that when I asked her to do this, but she really, really, really wanted to do this. And, because as we all know, mental health and what we're all doing about mental health throughout the state is very important. And months and months ago, when you and I talked about this, you said, I can get the right people in front of you, tell you the issues, and give you solutions. And I think that's something, Melanie, that this committee has really looked for solutions in rural health care and ideas that we can work with, especially in mental health, because we know what a tremendous issue it is. And with that, you got it.
Thank you. And you know, Chair Jaspers, there's not a lot of people. The list is short that I would do this for, actually.
I think, we can, you don't have to stand there.
No,
I mean, that's a portable mic.
Yeah, it is. But that's okay,
Okay.
right? A little bit of stress is good for things.
Okay.
I told some of your folks on your Rural Development Council this morning, I was just glad that my surgeon wasn't going to be live streaming this because I'm certain that he's very busy today. So we're going to make the most use of your time, and as Chair Jaspers has said, we're going to review a few of the challenges that we have, and it's just a few, and I think these are really a little bit more global to the community service boards that are in your rural counties, and we have very specific recommendations for your consideration. So Chair Jaspers, Chair Watson, Vice Chair Corbett, thank you so much for allowing us to be here and be part of this conversation. We're not always thought as of part of the healthcare system, particularly when you're talking about rural healthcare. A lot of times we talk about hospital systems, we talk about physician shortages, but we don't always get brought to the table to have those conversations around the challenges that we have as your community service board. As you know, you fund us as the safety net providers. So we're really excited to be here today. As you know, your community service boards are really public trusts. So we operate very much like some of your maybe city councils or your county commissioners in trying to affect the strategies of the state while also responding to local needs and finding resources to do that. And so one of the things I look at is when you look at a CSB, they don't all look the same because part of our role is to respond to the needs of the community, and resources in our communities are very different. And so that's one thing that you'll see, and we do that through a variety of means. And so one of the things that a lot of folks don't understand about CSBs is that we have a very large pool, probably the largest qualified pool of professionals in the state of Georgia for behavioral health. Across your community service boards in Georgia, we staff and employ approximately 11,000 employees. We are significant contributors into the state health benefit plan. And that is a little bit of a different role that we have than other providers when you start to look at the healthcare system. One of the things that Chair Jaspers and I talked about when you all met at your first meeting, which was in Jasper, which is where I come from, you were about 2.5 miles from my house. I literally could have rode my horse there that day. I don't know that I'd have had a safe place to tie him up, but that's where I started working with Chair Jaspers on allowing us to come and talk with you about what some of the challenges are. One of the things that we talked about that day was I recently, in this past year, was appointed to the Appalachian Regional Commission, Substance Abuse Advisory Council, to represent the state of Georgia across all 13 states in the Appalachian region. And I wanted to share a little bit of those recommendations because in September we finalized our report, which you have a copy of, and there's 14 recommendations. I'm not going to go through all those recommendations, but I thought some of those recommendations were interesting and I felt that they would inform some of our discussion today. And so across those 13 states that make up the Appalachian region, of course, you're looking at a lot of rural communities, and those 13 governors accepted all of our recommendations without any level of amendment. But the council charge was really to look at, within those 13 states that comprise the Appalachian Regional Commission, providing governors strategies to help individuals in recovery get the support and training that they need to maintain their recovery and to enter or to re-enter the workforce. And so if you're familiar at all with the work of the Appalachian Regional Commission, it's about economic development. And so this is looking specifically at the opioid misuse issue and how we can address some of the economic development issues of our community. We have individuals that have been in treatment and recovery, are employable, are ready to be employed, and sometimes have barriers to that employment. We have employers that are ready to grow, that are ready for a workforce, that they can't find the workforce to develop economically within our communities, and we think we can be part of the answer to that. And so part of our work was really centered around what we called the recovery ecosystem model, and I love that term when we start to look at what is an ecosystem. And so an ecosystem simply is a complex linkage of really multiple systems, collaborators, stakeholders that come together at a local level and try to address issues of persons in recovery and what that recovery to work environment looks like and where there might be gaps. And so while we have 14 recommendations, there were 4 that I felt like more informed some of our discussion today. One was to address a lack of coordination and alignment along stakeholders at the local, state, and federal levels. And this is really to help reduce fragmentation. As we are starting to see a lot of folks entering into the field of looking at the opioid misuse issue and the impact that it's having on our communities, there's a lot of money out there, there's a lot of grants out there, there's a lot of resources out there, but currently they are quite fragmented in terms of how are we going to apply those resources and what are the best ways to do that. And so one of the recommendations was how do we address that lack of coordination at a federal level, which will impact local and have a local influence. So the second was really to look at how do we look at the successes and create a playbook around those successes and how do we scale those. One of the things we found across all the individuals on the Substance Abuse Advisory Council was that our issues are very similar, regardless of whether we are in Pennsylvania, Ohio, Mississippi, Alabama, North Carolina, South Carolina, Kentucky, Georgia, Tennessee, any of those Appalachian Regional Commission states. When we start talking about the opioid misuse issue and the impacts that it's having on our communities and the economic impact, there really are some very similar issues that we're trying to address. And so how do we share those successes and how do we share those that are specifically scalable, particularly to rural communities? So then we also talked about and made a recommendation on funding pilots, and I thought this was a particularly interesting one because they're looking from a federal level to fund pilots directly into local communities. And so it's about looking at how you asset map what your resources are within your local communities and how do you allow those local communities to say, all the needs, all the resources, all the gaps are not the same, but how do we identify our gaps and then how do we develop a planning cycle that says we need to fill these gaps? It really builds on the strength and the resiliency of the rural communities around, you all know, because you're sitting on the Rural Development Council, in our rural communities, you have a lot of the same players regardless of what the issue are. They're very resourceful, they're very collaborative, they tend to be very strengths-based and they have a lot to bring to the table. So we really try to build on those kind of resources and that resiliency within those communities. And then the last one was really looking at some of the best practices for the legal and criminal justice system around diversion. This has a significant impact later in the cycle of this, of the ecosystem for folks who are employable. And so we need to look specifically at diversionary programs on the front end for those who are nonviolent offenders so that we can help them to be employable later on after they've completed and have entered into their recovery. So one of the things that we looked at, and this is one of the resources that was provided, is what we call an asset map. And again, this is an asset map that looks at who some of those partners are to help strategize and look at the resources and the gaps in resources within each community. And then how do you actually fund resources that go directly into a local level. And so it is one of the caveats that we worked with many times is we said, don't let local efforts be stunted by federal and state policy that limits our innovation. And so that's one of the things that we're looking at. And sometimes that's where we see barriers because we have sort of more global policy that affects maybe an entire state, but maybe doesn't fit for what the resources are that are needed in a local community to combat something that impacts either treatment, services, or even economic development. And so an example of this, which is some of the new work that our agency is, Highland Rivers, is engaging in, is the identification of advisory councils within our local areas. And so we've identified like Tier 1 and Tier 2. And Tier 1 would be those collaborators and stakeholders that we generally work with. Very commonly, maybe your criminal justice system, accountability courts, your law enforcement, maybe even your hospital system through emergency departments and identifying individuals in crisis and seeing if there's ways to view crisis and manage crises a little bit different to not burden the system so greatly. But then the second tier is something new, and it's something new for us in terms of how to bring those partners together. And it's how do we start to bring chambers of commerce, employers, technical colleges, how do we start to bring those partners together to create recovery to work pathways for individuals that are readily employable, and particularly for employers who are having a hard time filling the jobs that they need. So that just gives you a little bit of an appetite, and I felt like that you might be interested in some of that information and what has gone to all 13 governors' recommendations. Should there be something there to help inform some of your discussion, some of your work in this legislative session. So now let's move to some of the challenges, more specifically right here in Georgia, of our community service boards. And so we've identified really 5 critical areas, and some of these are not going to be much of a surprise to you. And one is the investment in crisis funds. And so we know that we've invested a lot in crisis funds over the last several years. Despite that, what I will tell you, as one of the largest crisis providers in CSBs, we have 3 community service boards and 74 crisis beds in the Northwest Georgia area, and 40% of the individuals that we see coming into our crisis bed units are folks we've never touched before and we don't know. So it tells you that there's a new capacity and we're a little bit behind the curve. Regardless, your community service boards across the state with their crisis stabilization units and behavioral health crisis centers served close to 100,000 unique individuals in the last fiscal year, and provided an 85% cost savings over a private system which was contracted to do state contracted beds. 85% cost savings. And so we do this much more efficiently, and we are accountable and resourceful with the dollars that we're given to try to provide those cost savings. On the state health benefit plan cost, that's a challenge that's pretty significant for us. As I had said, we have about 11,000 employees. But the way that we enter into the relationship in the state health benefit plan is we are treated essentially as a state agency. So every employee within all of our CSBs, we contribute 30% of their pay into the state health benefit plan, regardless of whether they choose the benefits or not. If they're covered under a different program, we still contribute into that. And so for each employee, we're looking at a load, and for any of you who run businesses, you can do this math pretty quickly. A minimum of a 41% load on top of whatever they're paying is calculated. And so that creates workforce capacity issues, because with that level of cost, we don't have the capacity or the capital to provide for increases in pay or to provide competitive pay. And so similar to FQHCs, they actually participate in the state health benefit plan with actually a different status as a contracted status, and also have access to the tort claims liability, which you also have for CSBs. But this state health benefit plan cost is one of the things that is a barrier for us in terms of building our workforce capacity. Our workforce pipeline, I'm going to hold that to our panel review because Dr. Johnson from Gateway CSB is actually going to cover a great deal of that, and I think you'll be kind of excited about talking about that. As well, the opioid misuse, Dr. Shannon Gordon from River Edge is going to cover a lot of that when we go to our panel view. And then that takes us to the criminal records as a barrier to employment. And so I've mentioned that just a little bit in some of the work that we have considered through the Appalachian Regional Commission, which is for us to be able to help folks that are entering into recovery and who've completed their treatment and are actively in recovery and are ready to work. We would like to help them gain employment, and we look at employment as meaningful work at a livable wage. And that's meaningful to their recovery, and it's meaningful to our communities because, as you know, and we've started to partner and discuss this issue with many of our employers, with such low unemployment rates, they're having a hard time filling jobs. And if you're in a community that can't fill jobs with low unemployment rates, where are you going to get that workforce to develop economically? And so we think we have some solutions to be part of that answer, but we're going to need a little bit of help from you in getting there and helping individuals and create a system that helps these folks to be a little more employable. So what I want to do right now, and again, Chair Jaspers did a great job of introducing me, and I hope that you guys can get through this whole meeting without him telling any stories about me, because he does know a couple. And we've known each other for many years. He helped me put my pastures together up in Jasper on my farm, and he'd probably disown me if he saw him today after this year's drought, but it is what it is. I'm going to let each one of our panel members introduce themselves, and I'm going to take a seat while they do, and we're going to talk a little bit more about some of these issues at length, and then we're going to come back with some very specific recommendations for you.
Good morning, I'm Dr. Shannon Gordon, and I represent River Edge Behavioral Health. To give you some frame of reference, our core counties are Baldwin, Bibb, Jones, Monroe, Putnam, Twiggs, and Wilkinson counties. So predominantly the area that I serve is indeed rural. I want to echo what Melanie said. To give you some frame of reference, River Edge provides economic development in excess of $140 million a year in the areas that we serve, and often are excluded from the conversation. And in terms of, there's a lot of support around local hospitals, but aren't considered as significant a provider in the healthcare arena. So thank you so very much. You, I'm sure, are aware that 115 Americans die of related to the opioid crisis each day. And one of the things that is of great concern to us is that when you look at per capita, Georgia does not draw the federal funds that are equitably ours, and that trickles down from that percentage decrease, that trickles down to the local community. If you look per capita to the counties that I serve, less than half of the money that should have come to rural communities came to us to serve, and that's of great concern, because I turn away people every day who are looking for help when I don't have medication-assisted treatment funds to serve them. And so that's my comment for now, and I'll pass it on.
Hi, I'm Kirsten Infinger, and I represent Georgia Pines Community Service Board. I'm the Outpatient Director. Nothing like running a little bit late to the House of Representatives. My apologies. Went to the wrong place. I have been with Georgia Pines for 8 years, and I'm here more as coming up with some concepts on ways to gain and retain staff and licensed providers that will assist with exactly what we're focusing on today.
Yeah, Mark Johnson with Gateway Community Service Board on coastal Georgia. I want to thank you all very much. You've already done a lot, and I know there's more coming to help with the mental health shortage in the state. Making psychiatry a primary care specialty helps. Funding the startup costs of a psychiatry residency in South Georgia, namely in Savannah, helps. And another significant thing that's already happened, one of our shortages I'll talk more about in a minute, is the shortage of our support staff, particularly people with masters in family therapy, licensed professional counselors. And in Georgia, Medicaid now funds those services just like they fund social work. May not pay the same, but they pay for it, whereas Medicare does not, which is a major problem.
Good morning. My name is Dana Glass. I'm CEO for Aspire Behavioral Health and Developmental Disabilities. We serve the southwest Georgia corner of the state, which is Dougherty County, Early, Miller, Lee, Terrell, Worth, Baker. And we also serve an additional 9 counties through some specialty contracts also in rural southwest Georgia. But in line with what Dr. Gordon said about us being a contributor to our communities, we employ about 376 people in those counties. So we definitely are a good, strong employer.
Who do you want to go next?
Just a second for Ms. Gordon. You talk about this half the money drawdown. I think everybody in the room is kind of looking at, what did she just say? That we're not getting half the money and...
Okay, if you look at just from a per capita perspective, Georgia is 3.22% of America's population. Okay, when you look at the SOR and STR, that's state targeted response and state opioid response funding, Georgia received 2.11% and 1.7% of those federal funds. Okay, so that's what I mean by per capita. The money didn't come to Georgia as it should have, and that's a state. I would submit that money had to be requested from the state level, and so that's an opportunity for improvement for future funding. And then when you look at the counties that I represent are 2.79% of Georgia's population, and we received, so according to, if you extrapolate out that money, we received less than half of the money we should have received on a per capita basis. Am I clearer?
Chairman Cooper.
Is that special money allocated for mental health that comes through?
Patty, would you hand her a microphone, please?
I was referring specifically to the opioid response monies that were approved in 2018 and 2019. And that's the money that Georgia is using to fund the medication-assisted treatment funds. And for example, we have been told, River Edge has been told that as of April, we're not sure that there's going to be any more funding for medication-assisted treatment for our community, that there will be no more contract funds for us. And that leaves me as a provider with people who are on medication-assisted treatment. How am I going to continue to support the ones I already have?
Why? Sorry.
Yes, ma'am, please.
I don't understand. We just got millions of dollars that went to DBDH, whatever it is, millions. And I mean, it would seem like the state would ask for everything it could possibly get. Where do you think the ball's been dropped, or what do you think happened?
I can only tell you when I looked at the data that the applications, Georgia DBHCD did make application. When you do the per capita funding, not enough was asked for. That's number one. Or not enough was awarded. Perhaps they asked and it wasn't awarded, but that becomes an advocacy issue. And then secondly, when the money was distributed in Georgia, I can only speak for my area, per capita, that amount of the money that should have come to rural communities did not come from DBHCD down to the rural community.
Okay, thank you.
Thank you, ma'am. And chase this rabbit. Chairman Stevens.
Still going down that. Mark might, from the coastal Georgia, might know that last year we did something a little bit different. In Savannah, the largest provider of mental health care was in the jails. And it was a huge number, 100% of it borne on the local taxpayers, none of it coming from the state and feds. So we did something a little bit different thanks to Chairman Parrish. We funded a different segment, as you might imagine. And the idea is these folks that get there, if they're in crisis, is to not put them in jail, which is borne on the local property taxpayer, but to put them in a diversion center for crisis help so that we can get those federal drawdown dollars at 6733, whatever it is, and then put it where it should be and get them in the proper treatment area. And that's where some of these federal, local dollars, the disparity is. Is that not true? And you're shaking your head, Mark.
Yes, I believe that is true. And that program is moving along. Just let you know, met with Major Gavin from Savannah Police Department, met with EMS leadership, fire chief, and behavioral health unit. So the community is very much coming together to be sure that everybody knows that those people need to be diverted to the crisis center. And that does indeed allow the drawdown, because all the front end of that crisis center is billed as outpatient. So that's where the drawdown occurs, and that's be very successful.
Let's let her go back into their part, but for Mrs. Gordon, I wish you'd just take some time and just jot this down as a question for us so we can investigate it further. Back to you. Sorry to interrupt you, but I knew we need to chase that.
Okay, so I'm going to discuss the workforce pipeline that we had previously mentioned. I'm an example of how we've utilized the federal funds to gain an intern and allow that person to work their way up, but kind of keeping them in by using this federal loan forgiveness program. So 8 years ago, I was an intern, and now I'm outpatient director. I have roots now in Thomas County, and I continue to serve that same population and intend to for many, many years to come, whereas I was in Florida. There is I'm not sure if everybody knows about it, but it's a federal loan forgiveness. It's $50,000 for 2 years of service, and that's for LCSWs, licensed LPCs, LMFTs, as long as you stay within your rural community and continue to serve that population. So the plan is
No more these little acronyms.
I apologize.
Guess what?
All of your clinical licensed providers. So your licensed clinical social worker would be an example from me. And so starting out as an intern from Florida State University, it would have been very easy for me to go and get a job in any city in Florida. But I interned, I worked with a high need, high risk population, and I fell in love. And then my current CEO sold us on this loan forgiveness. No. Allow me to clarify. I fell in love with the work. Okay. Yes. When I left my college, I had an offer with them. I had a private offer. I chose to go into public service. And it did not hurt that I knew that if I got my license that I could get this loan forgiveness. And again, for me, I can factor an additional $25,000 a year into my salary. So even though I get hit, a little harder on the front end, once I get my license, which for me takes 3 years, so they got 3 years right there, and then another 2 years it takes to completely meet that contract obligation. At that point, and we have many, many clinicians that have done this, and at that point, you've probably bought a house, you've put down roots, you've started a family, and now you call this home. The problem, the caveat to it, is that because this is a federal program, I could pick up and go. I could get qualified, I could get accepted into this program, and I could move to a different part of the country anywhere I wanted to go, as long as I found a rural community that fell under this same program. If the state of Georgia did that, we would have a lot more individuals that would get licensed, provide these services. This goes for nurse practitioners, this goes for physician's assistants, and psychiatrists as well. So we could greatly increase the number of providers that we have, giving the services to the community that are so critical for all of the programs that we're discussing today. And with that, we would be able to ask them for a contract. And maybe it wouldn't be 2 years. Maybe for the state of Georgia, we could ask them for 4 or 5 years. And we would have that factored in. They would, in their minds, factor that into their salary, because we know that we're not going to get the amount of funding that we, really need, but we could start trying to figure out some loopholes to get around that. And I think that this could be a really, really substantial one. We went from having 9 licensed providers at our agency over the last decade to having 25. We went from no interns to 250 interns. And we serve 6 counties that are an hour and a half. Some of them are an hour and a half away from a college, but we can get interns and licensed providers to go there because of this program. It's a great incentive. So I just wanted to kind of give you a little anecdotal example of what can be done and how those funds can be utilized. Any questions?
Yes, sir. Sure.
I want to ask you a question. I lost focus when Dominic asked if you'd fallen in love. I'm sorry. The program you're talking about, and that's what program is it? I just want to make a note of it.
National Health Service Corps, so NHSC.
Thank you.
No problem.
Thank you.
It's well worth looking into. And they also have opioid-focused loan forgiveness. So I think for that, I believe it's $60,000. So it's something to consider for that as well.
Thank you.
Chairman Parrish.
On this loan forgiveness program, we started a program here in Georgia a few years ago dealing with nurse practitioners and physician's assistants, and we've had pretty good success with that. Not a lot of people are aware of that, but if you choose to go to an underserved community, we have it set up that you can get a loan forgiveness for $10,000 a year for up to 5 years, I think it is. So this pretty much would take care of like our PAs, our nurse practitioners, to pay off their debt. And I think it's working pretty well. So, that's an example of what this legislature has done, and you can all be proud of the fact that they participated in this. So it seems to be working, and that may be the model that we need to look at, especially to get some of these licensed practitioners to agree to go to the underserved rural areas.
Yes, I think that that's a perfect example of how this can be extremely effective. And those licensed providers, we may have all the interns in the world, but they can't diagnose. We are going to want somebody who's got a lot of skills and expertise to treat somebody who's coming out with PTSD or, who's been in the state hospital multiple times. Those specialty programs, we need those people to come on board. So I'm grateful that you're doing that. That's excellent.
Chairman Cooper.
But these federal loans are available to anybody.
They're available to anybody.
Well, in those specialties, in that field.
As long as they're in a rural community.
Right.
Yes.
Okay. Well, who pushed it so that you know about it? Because it sounds like to me, rather than the state duplicating it with a limited amount of funds, and we do have a program for psychiatrists, that we ought to encourage people to take these federal funds, which are more generous than, so who let you know about it? Was it your school, or are you the one that's pushing the people that you interview to get it also? So how's the word getting out?
Right, so sure, now I'm obviously a proponent of that, and the CEO that I have now did. But again, I can't say enough that there is that caveat that I can go anywhere I want now.
Well, right.
So if
Yeah.
I go to school in Florida because I want to live in Florida for a couple of years and I want to move back home to live with my family in a different state, I can go and do that.
I understand that, but we've got lots of schools with social workers and psychologists, and it seems like to me that the CSBs ought to be pushing it, or their schools ought to be pushing the availability of this, and not that may be one of the places that up in the other areas they're not doing this.
I think as a system, we are pushing this as a benefit added, but it's not something that comes to us automatically. We have to apply and certify our sites. So example for me, serving 8 rural counties, we have to certify each site. We can't just certify as an organization, and we have to certify for different service lines. So it's not like a blanket statewide, option. You also have to apply for the funds to be able to receive it.
Well,
So-
it wouldn't be any different on the state level, and I'm sure that on the state level, we would want to make sure, just like the feds do,
Sure.
that the places you're sending these students are qualified.
Absolutely.
So it wouldn't be any different.
Absolutely. And I'm a licensed clinical social worker, and I have worked in the field for about 20 years. And I was fortunate enough for another state agency to pay my tuition. to go through a master's degree and work in the field. And here I am, 18 years postgraduate, completing service to my community still based on that educational opportunity I was afforded.
I just think there's a lack of getting this information out to students and sort of, and I'm not blaming y'all, but leaving it up to somebody else to get that information out. Oh, the colleges didn't do it. Or, letting people know about that the money is out there. It works for our federally qualified health programs. They get enough physicians, and we have 229 locations.
Yeah, Chair Cooper, I think that a publicity effort for all the state schools about what's available for loan forgiveness would be excellent to have. And you're
Somebody from USG behind us back here.
Chairman Jaspers, if I could take us in
Please
slight.
go.
Okay,
Take it on.
workforce development. What we're talking about, and the reason we talk about it, we're looking for ways to fix it, is in mental health, we have the equivalent of respiratory therapists and physical therapists. Imagine going to get your knee, your shoulder, your back treated. You get the doctor's office paid for, but your insurance doesn't pay for the respiratory therapy, the physical therapy. In mental health, it's the case manager, it's the counselor, it's the certified peer specialist, it's the certified peer specialist with youth. Those are the equivalent rehabilitation experts who it takes to keep people stable. And to get them stable in the first place, not enough to see a doctor once a month, any more than one visit to the orthopedic surgeon to diagnose your knee or shoulder is all you need to get it fixed. So first thing I want to address with workforce development is something we need your help with, that again, it is a federal issue, but we've done, I think, what we can on this in Georgia. In the rural areas, the greatest shortage, this is 77% of counties in America are short of these kinds of ancillary workers, the kind that are sitting up here with me and our staff. And part of the issue is that Medicare, who leads the way in so many things, will not pay for that licensed professional counselor, which is a master's level person, will not pay for that marriage and family therapist, which is a licensed person. Now, y'all have already taken action in Georgia that Medicaid will pay, but we actually need that passed. And certainly Congressman Carter's, who I get to talk to about this, and over the years I've talked to Senator Blunt of Missouri and some others. There is a Senate bill and a House bill. If you all could speak to your representatives locally, our senators, and your peers in other states. And I'll get you this, Chairman Jaspers. Senate Bill 266 and House 945. What those do is open the door for our staff in rural areas to be able to get reimbursed by Medicare, which means Blue Cross Blue Shield, Magellan, all the insurance companies now don't pay for that kind of service, and they justify it based on Medicare doesn't pay for it. And we've done what we can locally with Medicaid, but we actually need, that's had bipartisan support many times nationally. I'll give you a tip. It has often been killed in conference committee. It's often been killed when the Congressional Budget Office takes a very narrow view of cost. We're in a situation where we know the business cost of mental health and opiate addiction is a huge business burden. We're including family members who don't have that diagnosis, but they have presenteeism because they are so stressed out about what's going on in their families. So the cost is huge, and the CBO, they just look at, here's what we got to pay for the provider. That's one thing. It's a very important one. And there is a mental health Access Improvement Act up right now that particularly does focus on rural America. Number two, curriculum development and emplacement. So the kinds of programs we've got, loan forgiveness, internships, are excellent and do need to continue. They're not enough. One reason they're not enough is we suffer from a huge turnover. And again, that's a national issue. Nationally, people doing the kind of work we do have a 20 to 30% turnover of frontline staff. People come in, they don't have the skills, they burn out quick. They come in, they did or didn't do an internship and just don't find themselves equipped. One thing that we've done in Georgia, and Ron Evans did this for IDD. There's a program, there's a curriculum development program for developmental disorders with nurses, and it's run at Emory, so that nurses train in before they take the job. When they're training to be RNs in school, they are learning how to work with individuals with developmental disorders. What that has done is create an incredible job satisfaction and interest in nurses working with people with IDD. We need that kind of curriculum development, and we need it pushed down into the university system for our certified peer specialists, for our case managers. We need things like applied suicide intervention skills training, something that people take in their master's program. The cost of doing these things later on, we all worry about, because you got to take staff offline to train them. And so we really do need, if we can push training down into the universities, the kind of training people actually need when they come on the job. Some people will select out, so that'll lower turnover. Other people will come with better skills development. So that curriculum development is a very important thing to add to the practicums and the job shadowing. We need to support psychiatrists as specialists, just like we do cardiologists. And one of the pieces of that, because there is, whether you say it's 6,000 people short, psychiatrists short, or 15,000 psychiatrists short, I think we all experience that there's a desperate shortage. It is greatest in rural America, but there's a shortage in the cities. So our competition is very high to get psychiatrists. Training people, we know that as a rule of thumb, people stay within 100 miles of where they train. So training people in South Georgia, training people in Southwest Georgia is part of retention, but it's not enough. We also have to train people to practice in a community setting so that they are trained to do telemedicine with small towns and rural areas and primary care offices and FQHCs from the get-go. So that's how they, if you will, grow up in becoming psychiatrists. We also need to be able to train to provide that telemedicine where we have emergency rooms that do not have access to psychiatry, where we have jails that do not have access to psychiatry. So they, again, are familiar with that so that when they complete psychiatry training, they're very comfortable. One thing we're doing with the program in Savannah is when they get to their third year, they're going to have 2 half days of doing telemedicine. We put in 3 rooms just for that purpose. But we're also asking that in the July before they start that training, they live in a community that they're going to be connected to by telemedicine. And we don't want to put them in a condo. We don't want to put them in a hotel. We actually want to put them in the kind of house, location, on the farm, on the lake, on the golf course, that a doctor would live at if they're in Waycross or Statesboro or Milledgeville or any other, Forsyth, any other of our other towns, so that they get a taste of what it's like to live in rural America, which is very satisfying, particularly when you own some animals and get to show them, but as some of my peers up here do. The other model, so that, and I'll capture this in some bullet points because I know I'm going fast. There's another model that we also need to be able to expand what we do. Using the psychiatrist like a cardiologist. I mean, who provides most heart care in America? It's not the cardiologist, it's primary care. Who provides most diabetes care in America? It's not the endocrinologist, it's primary care. We need to be able to use that model in psychiatry to meet the need across the country. There's not enough access. More psychiatrists help, but even that's not enough. There's a model used in Indiana successfully where 5 hours of psychiatry time, combination of meeting with staff and telephone time, is actually producing support to 16 primary care, OBGYN, pediatric physicians, nurse practitioners. And the way it works is, and I'm way down in the weeds, but I figure we got to solve things down there. 2 master's level licensed people help with diagnosis in these offices. They also help understand the recommended medication algorithm, not a required, there's art to medicine, so it's not a required algorithm, but a recommended one. When anybody gets stuck, they get the psychiatrist on the phone and work through what the issues are, be it diagnostic or be it medication management. And then the psychiatrist meets with those master's people at least once a week for an hour to staff cases. But that's a powerful expansion of leverage, if you will, of using that specialist time. Talked about the workforce, talked about training them where they need to be, community focus, consultation liaison is what we're talking about. So psychiatry residency, like most residencies in America, have trained in academic big hospital centers because we're doing tertiary medicine. We're at a point, though, where we're feeling the need out the front door everywhere we live, to the left and to the right. And so that's why we have to train people who actually are trained inside that community setting to start with and use their skills and think about using them right there. I think I've said everything I need to say about that. I will certainly give you some good bullet points. Requiring insurers to cover the ancillary services. It is possible to have insurance in the state that does not cover mental health. Imagine an insurance policy being permitted to not cover heart disease as a category. Imagine an insurance policy not having to cover orthopedic injuries. We have insurance policies that are allowed to not cover mental health. I won't go into it, but the business cost, we've got a couple of papers on the business cost or the business advantage, if you will, of going ahead and treating mental health, going ahead and treating substance use disorder is phenomenal, as opposed to leaving all those conditions untreated. Basically, a couple of years ago, and then I'll pass the mic, I got asked to assess whether or not a big healthcare system with 26,000 employees ought to stop letting people be prescribed antidepressants on their healthcare plan. And so what, in doing the background research, I was able to show was, well, the insurance companies, the big ones, have already looked at that. And what they found out is if you restrict antidepressants, you drive up the prescribing costs of medicine for asthma, GERD, diabetes, et cetera. We're in an era, and we're in a good place, that people are no longer looking in a very tunnel vision way at these things. We're looking at the global costs. And that's where our state Medicaid directors have been very helpful, because they're looking at, okay, you drive down a cost over here, so then you drive up ED costs, you drive up hospital costs. That's the kind of strategic way we need to think big picture, and there are lots of things we actually can do. So thanks for your time. I know I kind of...
Thank you all. We're just going to take a half of a second to give you some of those very specific recommendations. So in our recommendations, what we're looking at is, again, to reduce the crisis reliance, improve access for Georgians, one, by supporting the growth of core outpatient services. And so I know in my area specifically, we've had a 72% population growth in the last 10 to 15 years. Our core outpatient services, which is essentially primary behavioral health care, we've not had any appreciable increase in funding for those services. And we experience that throughout pretty much most of Georgia. And so those core service dollars are critical to be able to provide access to folks when they come in the door. The most difficult thing we have right now as CSBs is a person who walks through the door and we can't see them. We've got, in some of our clinics, we've got close to 20 new people walking in our clinic, in addition to everyone who is enrolled and has appointments to be seen by clinicians within our agency. We can't get to 20 a day on top of that. That's if there was one thing that keeps me awake at night, it's that. Also looking at the, and I think Dr. Johnson spoke to this, but more specifically, looking at the Georgia Peach Act to ensure that we have coverage for folks with mental health or behavioral health disorders. We know all the statistics right now say 1 in 4, 1 in 5 have some sort of a mental health or behavioral health issue. But we have too many policies who don't cover that. And we end up providing care, and quite a bit of care that we provide for free for folks who can't afford the care because they are in a critical situation and because we're a safety net provider, and at the end of the day, it's the right thing to do to not leave someone unserved. And that individual doesn't necessarily qualify for the state funds that provide for us. But again, also, just to reiterate, work with our federal partners to include all licensed master's level clinicians in Medicare reimbursement models. So right now, in a CSB that is trying to manage the work with Medicare, if you don't have a Medicare provider, credentialed provider in that clinic, they will have to drive. So I have 13 outpatient clinics. I think maybe 5 of them can participate with Medicare. So if you're in one of those rural communities where I don't have a provider, then you'll have to drive to a clinic I do, or you'll have to find some other resources within that community. Again, Provide CSB is the same state health benefit plan status as the federally qualified health centers, just as an example. Support, we've talked a lot about our pipeline development in workforce, so really to look at that pipeline development. And just a note on the National Health Service Corps, your community service boards have participated in National Health Service Corps for decades, considerably. As a federal program, though, that program can change each year, so I have had staff who I have recruited and who they will get awarded one year, not awarded the next year, awarded maybe another year, and so sometimes it's a bit of a crapshoot as to whether those funds are truly going to be available. I think we can do a much better job of that within our state and keep folks and professionals within our state. Ensure the distribution of opioid misuse dollars on more of a per capita basis, and make sure that some of those get to the rural community. Again, several states have enacted second chance laws, and those second chance laws are for nonviolent offenders to look at how can we invest in diversionary programs that will help them to seek employment and be part of our economic development solution later on. Again, there's plenty of states who've looked at second chance laws, and we would be more than happy to work with you on that or to provide any resources, but I'm sure you've got staff who could do the same. The last thing is the Workforce Innovation and Opportunities Act, which was passed in 2014, and looks at, I know we've got regions within Georgia. We have had lots of conversations, and even in all of the data, healthcare is the biggest shortage. It's the greatest opportunity where we need workforce innovation and opportunities. But only 2 of those regions in Georgia are focusing on healthcare. And so, when I look at that and I look at that data, I'm like, well, why don't we really put an effort towards the healthcare aspect of it? Because this is, from all of our data, it is the biggest shortage area and it has the most impact on our communities. And so we could look at what our strategies are in Georgia and see, could we take some more of those regions and perhaps focus more on healthcare? Because I think that there are a lot of things that the Workforce Innovation and Opportunities Act can help provide if we can maximize that. We are really at the time, and I do not want to upset Holly because she has been so wonderful to work with us, and so we were happy to answer whatever questions that you have that Holly will allow you to ask.
Hey, you're right. We have time, committee. We've had someone council coming, so we've got time to answer any questions that you may have. We'll start with Chairman Perkle here.
Thank you, Mr. Chairman. Mark, one of the interesting parts of the comments that you had that I hadn't thought of that I'm glad someone did, the Indiana-based model of basically training family practice professionals and OBGYNs to essentially triage mental health cases, since we have such a shortage of psychiatrists out there. What do you need from us on that, or just get out of the way and you're just telling us about it? Is there something that is preventing that model from increasing across the state so that we can provide basic mental health care for a maximum number of patients in a triage type setting?
I think what would be very helpful would be funds for a pilot, because not a lot of people are going up to Indiana to look. But I think if we could pilot that, and so obviously funds to do a pilot, it's putting those 2 licensed master's people in the office who then assist very busy primary care practitioners and then make the phone calls to the psychiatrist. So I think probably a couple of pilot projects would get it up there, and they would have the ROI to show, yep, this is actually very beneficial, and we get some real reports, which is what's happened with a lot of the law enforcement efforts, is we've had some pilots and then move forward. So you'll notice I'm not somebody who asks for lots of funds for lots of new programs, but I think pilots are very valuable because they show we got the money some places to take care of some things.
Chairman Cooper.
Okay, in the very beginning, you mentioned tort claim liability that the federally qualified health centers have and you don't have. What are you talking about? I haven't heard that one.
We actually are covered under the tort claims liability. I think the issue around that is the federally qualified health centers, which are probably the most similar partner we have in the state to primary care. They also have the opportunity to contract into, and with a different status, into state health benefit plan and receive those benefits for their employees, but it's a different status level than what community service boards are. We actually are treated more like a state agency. So, for instance, my agency, we have grown in the last 5 years or so. So we've almost doubled in the number of staff. We've gone from 325 staff to 640 staff. But the compensation that is drawn down through the budget has not increased to increase pro rata with my, that's based on the basis of my employee population.
Okay,
if that
but-
makes sense.
But when you talk about torts, and they have a special thing where the feds pick up any, liability cases. So when you said tort claims, I thought you were talking about legal cases.
So that is, I think what we're looking at is what that status is. I think in one of your earlier meetings, when the FQHCs were presenting, they were actually talking a little bit about their status and that they actually have tort claims coverage for their liability.
And so you were saying.
And we do also.
Okay, so if somebody says you do something wrong, you did something wrong, they have to, the federal government picks up any.
Or the state, right? We work very closely with DOAS.
Okay.
And so it was really just trying to look at the of that status, which is different, not so much about the tort claims, it's really about the state health benefit plan.
Oh, okay, because I didn't understand where the problem was with that.
Yeah,
Okay.
yeah.
Chairman Taylor.
Mr. Chairman, just a quick question. I'm working with one of the mental health service providers in my community, and they appear to be having, I'll call it compensation difficulties through the various types of Medicaid that we have, and whether it be for foster children. Are you seeing the same thing? Is that something we need to look at and address?
So, are you talking about with the care management organizations?
Yes.
I would say it this way. The care management organizations' authorization processes are what restrict access to payment and therefore access to care. Is that a good way to say it? Yes, we see the same thing.
Okay, is there a way to alleviate that? Are they limiting visits? Are they making it too hard to get authorization?
Limiting
Is it different
visits.
by different providers of the Medicaid program?
It is different per care management whichever care management organization is covering that particular child or family, and it is limiting visits, is the best way to say it. And it has, since the advent of CMOs in Georgia, since 2006, we have seen a decimation of the care for kids.
I can add a little bit to that too. So when we're doing an authorization, we might submit it and we say that the child might benefit from multiple groups a week and a therapeutic intervention, and they tell us we're not going to approve that. We're only going to approve them to have one group a week, and so then we're cut back on what we can provide based off of what they're willing to authorize. So it's a combination, and they're directly connected.
Do you know what criteria they're going by, how they're making the judgments? Do you have a way to appeal it, or is it just too much red tape?
There's a lot of red tape. Because, what we would think would go through with one, we submit again with the exact same, what appears to be the same criteria, and we might not get it.
That's the same thing I'm hearing. It's not a consistent
Correct.
decision-making, and then it also varies from provider to provider.
Correct.
All right, thank you.
The only thing that I was going to add to that is one of the things that we see, we're in 57 schools in the 8 counties that we serve, and a lot of what we do is a skills-based intervention with the children that we serve. An 8-year-old's not going to be able to do as much insight-oriented therapy as you or I may be able to do as an adult, but they want to authorize those high-level, high-intensity therapy services that require that fully licensed clinician that most of us don't have that full continuum. I mean, we've got one that can maybe see them once a week, but not to deliver those services in a more consistent, high-frequency manner.
Thank you.
I just want to follow up just a moment on what Chairman Taylor, just my curiosity. So our children who are wards of the state, as I call it, our foster children, are they subjected to this difficulty in getting treatment too?
They're covered.
Or limited, I guess.
They are. They're covered by these care management organizations, so they experience the
So that their
same.
treatment's throttled back is what you would call it. Okay.
Yeah, and so we do have some plans that don't cover mental health as far as insurance in general, but the CMO issue really is, if your doctor says you got to run your hand up the side of the door to get that frozen shoulder unfrozen, we got red tape to be allowed to pay for the person that tells you how to do that. That's my equivalent, yeah.
Chairman Green, there you go.
Thank you, Mr. Chairman. Donna, she is absolutely correct when she's talking about Southwest Georgia. She is our first line of defense when it comes down there. Our law enforcement people do not have the places that they can keep individuals, but they lock them up. Are you seeing this as the major trend in Southwest Georgia?
So it certainly is a challenge. One of the things that that's a barrier for us is we're not able to bill and get reimbursed for services provided in the jail setting. So we've had to get creative about our partnerships with law enforcement. We've really focused a lot on, identifying when somebody might have a mental illness so that we can intervene early and intervene often to hopefully avoid, that incarceration. But we've also formed creative partnerships to be able to provide some services on a limited capacity. But most of our sheriffs in our local community, that, most of our sheriffs, a good part of their population do have a behavioral health disorder or substance use, or both.
How can the legislature help us in doing something to help y'all with this?
So I'm going to name one thing, and of course I realize these are complex and they're multiple pieces. When we talk about intercepting people, we're talking about basically nonviolent misdemeanors to keep them out of jail. Of course, somebody's done something violent or committed a felony, they're going to jail. There's still that pre-adjudication state, so they're not in state prison yet. In the state hospitals, for people with psychosis, hallucinations, delusions, there is state law that permits, it's a two psychiatrist doing an independent psychiatric evaluation. If they agree that they've got a psychosis and need antipsychotic medication, they can go ahead and administer it per state law without that person's agreement. Right now, we don't have that in the jails. And so you'll have sometimes 10 officers restraining somebody. I mean, and these aren't people that can be diverted. They may have committed a felony, assaulted somebody. The one caveat to do that in the jails, and we've certainly got some legislation that would show us the way, is once they become of right mind again, because of their civil rights, they do need the right to be able to say, I want to be able to plead NGRI, so I do not want to continue on this antipsychotic medication. But from a human being viewpoint, for most people, not being psychotic is a whole lot nicer than being psychotic. So being able to have a state law that would allow in the jails that same two psychiatrists or two nurse practitioner evaluation rule to let people be given that long-acting injectable antipsychotic would be very, very beneficial, with the caveat that once they're of sane mind, they can say, nope, I want to be psychotic because that's going to matter to me when I get to court. We've got legislation that does that already in the state hospitals.
And I'm also in deep Southwest Georgia. We have a contract that we've set up with one of our jails in Decatur County, and we actually go into the jail, we do assessments in the jail, we have a nurse practitioner that goes in and they prescribe medications. And so basically, instead of the jail having to bring the inmates to us and provide services on an outpatient basis, we're going into them. It's a pilot, it's been fabulous. So we're hoping that we're going to continue to expand that. If we can get more jails on board with doing a contract direct with them, I don't think I know a CSB that would refuse to go and help out. And then that continuity of care when they come out, because now we've stabilized them, we're going to reduce their recidivism, which is going to reduce taxpayer dollars and everything else that comes with it. And we're going to have a healthier community in general.
So we've had a similar response in Northwest Georgia, particularly as we were the first hospital closure in the DOJ settlement. And those communities have seen it for quite some time. And I have 12 counties which I serve. And what I will tell you is the county that has the most money contracts with me to provide the behavioral health services in their jail. And the county that has the least money is probably the poorest county in that whole 12 counties, also contracts. And they both find it as a huge benefit because we are able to connect with those. Now, I've had another county that, as many of you know who are in my area, I will come down and meet you at the Capitol and we'll talk about issues and I'll see, what can I do to help you and are there things that you want a little more education about. And I had one representative tell me one year, this sheriff of this county keeps coming to me time and time and time again about all the behavioral health. I have been attempting for 2 years to get a meeting with that sheriff to talk about the issue and to see, can I provide a solution for you? And I most likely can provide the most economic solution, the best use of your resources. But I'm going on 2 years now and I have not been able to get the meeting. And so what I would actually say is that when that occurs, you know what, your convening authority is what would be really helpful. Because sometimes we just have a hard time getting to the table to have the conversation to provide the solution.
Chairman Parrish, you were next.
Yeah. Thank you. Mark, talk to us a minute about, we all, I think, are aware of the fact that there's a severe shortage of psychiatrists all across this state, and especially in parts of South Georgia and rural Georgia and this sort of thing. Talk to us in this group a little bit about how you've done some creative things to help us establish some new residency programs in psychiatry down in your area that this group has supported and put the money in to help you get that thing started. And that could be one way to help get us out of this hole that we're in by providing you more providers with these residency programs. Talk to us a little bit about that and what we're doing, please, sir.
Thank you, Chairman Parrish. So I'll be down in the weeds, nuts and bolts. So you all funded 2 years, $480,000 of startup funds. What that allowed us to do back in 16 and 17, man, my years off, was go ahead and hire the faculty you need to hire the program coordinators you need to hire to, if you will, knit together the program. And so we then applied for ACGME accreditation to have well, first we had to apply to be an institutional sponsor. Those have historically been medical schools, big hospitals. The CSB Gateway applied to be that institutional sponsor. Once we had that approved, we applied to be the psychiatry residency accredited program. And so we were accredited in February of 18. We began interviewing for this year's, the class that started July 1st this year. We then began last fall interviewing. We got 1,175 applications of people that were wanting to come to Savannah to train in psychiatry. Splendid. Well, we have 6 slots per year. So psychiatry is a 4-year training program. We were approved for 24 slots. Because we had 0, we went ahead and took 8 people. And they have started now. So they spend time training in the CSB doing outpatient. Our program has them train at Georgia Regional Savannah to get some of that very intensive experience. And the kind of consultation liaison we built in the program is inside the FQHCs and inside the family medicine outpatient program. So they'll get a little bit of in the hospital consultation liaison, but we're really aiming them to know how to provide that to primary care physicians. They will also, as I've said, they'll be doing half a day, 2 half days a week. When they do their outpatient work, they'll be doing 2 half days a week of telemedicine. They will also be participating in our school-based treatment in the APEX program. And they are going to be doing ride-alongs with the behavioral health unit for the police departments. And what else? So the Behavioral Health Crisis Center, which y'all funded, they when they first start, they spend 4 months there on that 24-bed inpatient part of that. in that first year. They also spend 2 months in that 24-hour walk-in emergency part of that. They come back in the second year, do another 2 months in that walk-in emergency part. And then in their fourth year, they come back to that BHC as a senior resident with the experience to act as junior faculty over the whole shebang. So we're really trying, I mean, that's, really networking them with what's going on. They will also serve on ACT teams, those assertive community treatment teams, which are a hospital without walls approach. They are expensive, but they're a whole lot less expensive than having people in the hospital. And so they'll also get experience there. In addition to that, we have, of course, regional community collaboratives. We have Step Up Savannah. We have a annual mental health symposium that the county sponsors and funds. So we're also having the residents participate in those county-wide activities. We have put them in the same suicide intervention skills training that our own staff go to, that the sheriff's department, the police department, the schools go to. We have a suicide prevention program that's now done an hour-long suicide talk for over 8,000 people and has trained over 300 people in the actual skills to use in intervention. And that doesn't take a mental health professional. That's all role play based. So we put them alongside people in the community, and we're telling them, we want you to do community projects. You're here to help the community improve its health and wellness. You're not here to be out in an office by yourself or in a hospital waiting for somebody to get sick. Your real goal is prevention, prevention, prevention. And I know down Southwest Georgia, you're doing a first episode psychosis program that we actually want to copy. The best thing to do with psychosis, and I hope it's unethical in 10 years to let anybody be psychotic more than once. The best thing to do with psychosis is treat somebody immediately. Sorry, a little long-winded. My apologies.
Yeah. Chairman Hatchett.
Thank you. Thank you, Mr. Chairman. I have two questions, if that's okay. Separate lines. First question, just to build on what we heard a lot of yesterday, of those 8 residents that you have, what percent of them are from Georgia? Or how many of the 8 are from Georgia?
I'll be real fast. One was already working as a doctor in DeKalb and also in Milledgeville. Another one is a graduate, #1 graduate, by the way, Medical College of Georgia. I think 3 or 4 of those 8 were from Georgia to start with. Oh, I'm sorry, there are more. 5. Because we got a couple people that we took some people that weren't immediate graduates. They were already living in the state, had been here 2 or 3 years. So altogether, I think we got 5 people that were already Georgia residents. Same thing's true this year. We're taking 6 more. We're halfway through the interview season. We're getting a lot of Georgia applicants. When we search, we look for connections to Georgia, family, residence, school, anytime you've been in Georgia. That's who we're looking for.
Thank you, because it's proven that if they are from here, they tend to stay here. So, and the second question, and I don't think I missed it when I was out, so if I did, I'm sorry. The statement about SHBP status between CSBs and FQHCs, I don't know that anybody, I'm not really sure exactly what you're saying. I mean, so employees from both entities are eligible for SHBP, correct?
Correct.
So it's how you are reimbursed for covering, what's the question? I don't.
My best understanding, correct me if I'm wrong, our status with SHBP is as though everybody who leaves us as a retiree will carry that into that coverage into retirement. So we are charged a higher rate percentage of that salary. The fact is that our employees do not carry that coverage into retirement. The way that federally qualified health center staff are charged is as though they will not carry it into retirement. And so it's a lower percentage. Is that correct?
But you're both eligible to carry it into retirement,
Yeah.
correct?
No, we're not. We are not eligible to carry that into retirement. And we are, I think what our status looks like when you look at it and when you look at the law is that we are treated a little bit separately, and it is akin to a state agency. And so we pay in for every employee, regardless of whether they select state health benefit plan or not. If they are maybe covered under a different, if their spouse has coverage and their coverage under that program, we still contribute 30% of their pay, their total pay, which would include overtime, on-call, any of their pay, into state health benefit plan, regardless of whether they're receiving the benefit or not.
Because you're funded on basically a grant basis, and then you're just billed a percent. Okay.
Mm-hmm. Yes, although the amount that we are reimbursed in our budgets and contracts is not pulled directly from what our head count is that we're contributing on. It is, I'm not sure where the algorithm originated, but I think it's probably a little bit dated. And so that delta for me is close to $1 million a year. And I think we can provide a lot more information to that, because I think there may be some questions to that.
We'll move on.
Sure.
Because y'all, but Chairman Stevens. And then, for committee, you've got these people, they'll be here for a little while, and we can ask them some questions during break. Go ahead.
I appreciate it. Whenever you talked about that you contract with the sheriff, the local jails and all that, but still, it all falls on the local property taxpayer. We've got to do like we're trying to do in Savannah and divert these people, because it's the inappropriate place for these people to be treated. So even the fact that you contract with the local sheriff to do the treatments there, 100% of that falls on the property taxpayer. We've got to divert these folks to the proper treatment area, and we've got to start drawing federal dollars to pay for what is the appropriate place to pay for them. Just the point.
And I think we would all agree with that. And I think, one solution that I see is we actually all have to be able to get to the table and be very solution focused on what we can do. I have met with a recent jail in my area that provides a great deal of mental health care. And they know that in a community where we have lost a state hospital, they actually come, and you probably know the community I'm speaking of, they come for their mental health care. And recognizably, if I've got 20 people a day coming in that are new, and I don't have the capacity to see everybody who's on my rolls and 20 new people a day, we've got to start to look at what that access looks like and how we fund that. And so my last parting thought, Chair Jasper, is what I would invite all of you, and if there was any call to action at all, I would say please get to your local community service board. Find out who we are, talk to them about their challenges, talk to them about their solutions for what you see in the community. Mental health is becoming a much broader conversation, and so I really just would ask, please visit your community service board and get to know who they are. They will open arms allow you in and be willing to share with you and discuss some of these things further. And again, thank you so much for inviting us here and allowing us this amount of time to be part of the conversation.
Well, thank you. But my chairman of my health committee, which I'm a member of and sat beside her many years.
Right. I just want to know.
Chairman Cooper.
Okay. Do you have the bill where you want to be able to give IM medications when people, are not able to say they want them? Are there other states doing that, and doing it anywhere?
I don't know about other states.
All right. And if you have a piece of proposed legislation, send it to me. Let me look at it. Okay, I'm an advanced practice nurse, and my specialty was psychiatric nursing. Send me that. I just think there might be constitutional problems with it, but we can certainly look up and see if we could help our jails out.
Yes, thank you very much. We'll do that, and we'll share the constitutional history.
Okay.
Thanks. So, Melanie, I think you got a lot of questions today, and the interest of this committee in the mental health of the state. I know that you and I talked about it, and it's really there, and it's very valid. But we appreciate y'all coming. Thank you very much. So our next presenter is Dr. Ruiz? Ruiz, thank you, Mr. Chairman.
Thank you.
From the Southwest Health District, he's Director of Telemedicine, Telehealth. and rural health initiatives. And we've heard the word telehealth a lot in the last couple of days. So as you get a cup of coffee, get back, and he'll get set up, and then he'll start. Y'all want anything? You want anything? I gotta get a cup.
I didn't get up yesterday.
They're just kind of low or
Sleep
something.
last night.
Is it they're low or something?
It kills. I'm telling you.
Well, I'm a big old boy now.
I thought I was going down, man.
I'm a big old boy. Hey.
With regard to telehealth, the composite medical is considered a rule right now to make it so that before you can offer a telehealth service, you have to have seen that patient in person first. And we have issues with that just because, I mean, as you heard, if the patient's in India and they're not on site, and you can get cited by telehealth, you obviously have not seen that patient first. And so, we are going to present to them the next, I think it's in December, they're probably going to be on the top of this, but the docs are really digging in on that because they feel like,
Or stepping over.
yeah, and they think that, seeing the patient first is a necessity. It's not what they're doing in other states, but it's really going to put in favor, especially when they go to,
Yeah, they want to go to jail.
right, and
That's a
so,
little low. I mean,
we're gonna tell them we don't want them to adopt this law, right? But they're kind of leaning in that direction, and I think that goes against what y'all are trying to do here. So just be cognizant of that.
send me information. And I'll ask them.
You give them, hey, Jim.
I gave them to her, stood back here.
You gave them to Holly?
Are these handouts that we go out?
Then that's the plastic.
Are you going right there?
No, he's last.
We don't want to go out right now. You get a cup of coffee, I'll be right back. You want to start them or you want to?
No, I'm not up. Right. Everybody's up anyway.
How you doing? Good. Ready to go home. Did you stay all night last night? You stayed all night?
implementation of rural health telemedicine programs in all 159 counties through the Department of Public Health. With me today, I have Dr. Ruiz, and I'll let him introduce himself.
Thank you. I'm Dr. Charles Ruiz, and I am from the Southwest Georgia Health District, and I'm pleased to be here today to represent public health in general and to represent rural health in general and public health specifically. Let me tell you a little bit about how I got here. I was born and raised in Cordele, which is in Crisp County, and when I decided I wanted to be a physician, I tried to pattern myself after my professional hero, and that was Dr. Perry Busby in Cordele. Dr. Busby was the brother of the late Governor George Busby. And so I went to the Medical College of Georgia. I trained in Macon, became a board-certified family practitioner, and went back home to Cordele and practiced family medicine. And I was fortunate enough to be in the same building with Dr. Busby. Now, I never became what he was, so I fell kind of short, but I count myself as fortunate that my career overlapped with his. About 10 or 12 years ago, Dr. Busby retired, and he was the physician representative on the Board of Health in Crisp County. And he submitted my name as a replacement. And at that time, I really didn't know all that much about public health, but it was an honor that he mentioned me as a possible successor. So I accepted the role, and I became a member of the Board of Health in Crisp County. And I really enjoyed my time there. After 25 years of practicing medicine one-on-one, one doctor, one patient, I found it very exciting and refreshing to learn that in public health, we deal with all sorts of issues on a much broader platform than just one-on-one. So about 4 years ago, when a position came open for a public health director in Southwest Georgia, I was ready for a change in career, so I volunteered for the spot, and I got it, and here I am. And I have really enjoyed my time in public health. It's a great place to work if you want to see good things happen, to promote better outcomes for the population. It's exciting. There's great teamwork in the Department of Public Health. For those of you who may not be terribly familiar with the way things work in Georgia, let me give you just a kind of a brief anatomy and physiology lesson. All 150 counties in the state of Georgia have a public health department, and most of the public health services are administered locally at those health departments, but they don't function independently. The county health departments are clustered into districts. The size of the districts will range from one county to 15 or 16. There are 18 of those districts in the state of Georgia, and that's what our map is showing you here. I represent the Southwest District down in the corner, kind of tucked in there between Alabama and Florida. Each health district is led by a physician, and we have an entire district team that supplies support to those counties. An example of that would be our tuberculosis control or our Office of Information Technology. Those are district level services. And then we have state level services, the folks primarily in Atlanta who supply things like emergency preparedness guidance, state epidemiology services, and that would include things like control of infectious disease like measles, hepatitis A, and so forth. And then sitting at the top of that pyramid is Dr. Kathleen Toomey, our Commissioner of Public Health for the state of Georgia, and of course she serves at the pleasure of Governor Kemp. So that's kind of how things work in Southwest, in public health in the state of Georgia. And I know we're here to talk about rural health today, so I'll do just that. In our district, we're going to have a celebration of our employees next week. We haven't done that in the last 3.5 years, so we have a day set aside for an Employee Appreciation Day. We're going to get together and have some education, some team building, and some fun and some food, and just celebrate all the great work that our employees do. A part of that celebration involves some games, and one of the games that we're going to play is Public Health Family Feud. So like the TV game show, we sent out surveys to get some answers to some questions. And one of the questions that we ask our staff is, name one of the great things about living in Southwest Georgia. Some of the most frequent answers that we got were things like no traffic, living close to the beaches, country life, fresh produce. And in fact, those are some of the reasons why we live in the rural part of Southwest Georgia. We enjoy it. We don't want to go any other place. But it's a double-edged sword. For instance, because we live close to the beaches, that puts us in the path of hurricanes like Hurricane Michael. And because there's no traffic, that's probably because there's no place to go. And that's meant as a joke, but when it comes to public health, it's very much reality, because we have limited resources. And we can't just get in our car and drive down the street to see a neurosurgeon or an endocrinologist. I mean, the list goes on. There are many services that we don't have in rural Georgia, and that contributes to some of the poor outcomes. And that gets around to kind of, I think, why we're here today. If you're familiar with the county health rankings, you'll know that each year the University of Wisconsin publishes a list of county health rankings. It's for the entire country. It does not compare state to state, but it looks at one state at a time, and it compares county to county. It looks at outcomes, and it looks at health factors. The outcomes is kind of where you've been, the results that you've had, and the factors is it takes a look at your behaviors and your resources and kind of predicts where you might be going in the future. Well, every year it's the same thing. When those rankings come out, the best scores typically are in the north part of the state, around the metro area. And the worst scores tend to be in the rural counties and in the counties that are south of Atlanta. So that's the reality. That's what we deal with. And we are always trying to find ways to improve our outcomes. And we'd like to spend the next few minutes talking about some of the things that are going on, some of the innovative approaches that we're taking to some of our problems. We'll consider some of our successes and maybe consider some of our challenges as well. So a good place to start may be with prenatal care. For years now, one of the priorities for public health has been what we refer to as early brain development. And what we're talking about there is an approach that promotes every pregnancy as being a healthy one. Every child being born as close to full term as we can get them, and born into a family that is socially and economically and spiritually ready to take care of that child and nourish that child, so that that child can go to school and learn, and by the third grade be able to read to learn. So a lot of our efforts are all channeled in to that process, trying to make it to be as good as we can. So where it comes to prenatal care, in Southwest Georgia, we're hurting for obstetricians. A year or so ago, I counted up all of the obstetricians and the midwives in the entire 14-county district, and we had about 22 people taking care of obstetrical needs for over 300,000 people. A lot of those obstetricians are like me. They're not spring chicks. And when obstetricians get to be in their late 50s, they tend to back away from delivery services. And I'm really worried about what's going to happen in Southwest Georgia if we don't do something to beef up our supply of obstetricians. My predecessor did something that was revolutionary about 10 years ago. Dr. Jacqueline Grant was there in the role that I occupy now. She is an obstetrician, and she brought to Southwest Georgia what's known as centering pregnancy. Let me tell you a little bit about what that is, and I think you'll find it very exciting. Traditionally, when an expecting lady goes to the doctor for a visit, it's one-on-one, one patient, one doctor. And that works fine in most cases. But what we know is that a lot of pregnant women don't always keep their appointments. A lot of pregnant women don't absorb the knowledge that they really need to promote a healthy pregnancy and to take care of a child. A lot of pregnant women don't know what to do after the child is born. Sometimes it's because of literacy, sometimes it's because the home environment is not nurturing. And so Years ago, the concept of centering was developed, and the way it works is you get ladies who have similar gestational ages, you bring them together, and instead of going to the doctor one-on-one, they see the doctor or the provider as a group. They'll come together for scheduled appointments, and that's usually every 4 weeks starting at about the 16th week of pregnancy. And they'll have their regular OB checkup, but also there will be time for socializing, and then they sit around in a small room with a group of maybe 10 to 20 patients, and they will receive an educational topic. It could be on nutrition, it could be on safe sex during pregnancy, it could be on breastfeeding or birth control after the pregnancy. And so this program came to Albany, Georgia about 10 years ago, and at that time you could count the number of similar programs in the state on one hand. And that program has existed nonstop since then. One way we know that it's helping is by looking at low birth weight rates. The rate for the state of Georgia is somewhere around 10%. In Albany, Georgia, that rate is around 14 to 15%. But for these women who go through this program in Dougherty County, that rate is around 6%. So that's a success story. One reason why that works as well as it does is because of technology. We have a perinatologist in Atlanta, Georgia, well, in Sandy Springs, Dr. Ann Patterson, who provides education to those ladies that are going through the centering program, and we do it by telemedicine. Dr. Patterson is in her office, and for 3 sessions during the pregnancy, they wheel a cart into that circle, and she's there. She can see all the patients, she can hear them, and vice versa, they can see and hear her, and she teaches them about important topics related to the pregnancy. We couldn't do that without telemedicine. We get some telemedicine support from Salima and her crew, and I'm going to give her a chance to talk about it a little bit more. We also have a program that's similar to that in Ellington, Georgia, which is in Colquitt County, just outside of Moultrie. And in that program, we're not currently using the telehealth technology, but we have great success there. Their low birth weight rate is around 3 or 4% in that program. So the message there is centering pregnancy has a great benefit to society, particularly where the need is the greatest, and telemedicine helps us to deliver that. Another way that we are using telemedicine currently is in the infectious disease arena. In the state of Georgia, almost all tuberculosis cases are treated by and monitored by public health. One reason for that is there are difficulties in treating tuberculosis that we don't deal with typically when we're treating something like typical pneumonia. Tuberculosis takes a long time to cure. A person has to be on medication for 6 months to a year, really. Tuberculosis is airborne. It's not the easiest thing in the world to spread, but it can be spread by close contact if you share a space with someone long enough. Another problem we have with controlling tuberculosis is with compliance. Probably everybody in this room fails to be compliant with all their medication. I know that's true for me. But with tuberculosis, it's particularly a problem. That population just tends to sometimes move around, and it's hard to make sure that they're taking their medicine. And if they don't take it properly, that can lead to resistant germs, and that becomes almost impossible to cure. So in treating tuberculosis, we never give medication to a patient in bulk and say, here's a month's supply, you just take it and do the best you can. With tuberculosis, each dose is observed by a medical professional, and that can be very time-consuming and cumbersome. So sometimes patients will come to the health department to do that, but very often our professionals will go out to where they live or where they work so that we can observe that therapy. We can count each dose that way. Well, that's hard to do because some of our patients work. They're mobile. They're here and they're there. They may work in a county that's different from where they live. And it's often that we have to send our nurses out after the sun has gone down and the weather may be bad and it may be a neighborhood where you really don't want to be after dark. So something that we've been doing for the past year or so involves telehealth. What we are now able to do is for our patients that have a smartphone or another device that they can use, we can use the technology like that to watch them take the dose without having to physically be there. And that has improved the ease of delivering that medication, which translates into quicker resolution of the cases. It's easier and safer on our nurses, and it saves time. So that's another way innovation is working to improve outcomes in rural Georgia. In Thomasville, Georgia, we have a travel clinic, and it's the only one currently, the only public health supported travel clinic in our district. So people who are going abroad can go to the health department there and they can receive education and counseling specifically catered for their destination. So we can tell them about which diseases are prominent wherever they're going to visit, and we can prepare them with vaccinations if vaccines are available or prophylactic medication. So my office is in Albany, and it's about 95 miles down to Thomasville. And so to keep me from having to make that trip down there, we use telemedicine. I can sit at my desk and look at my computer, and I can see the patient down in Thomasville, and I can provide that service without ever leaving my office. And consequently, the patient doesn't have to drive to Albany either. One of our problems, of course, everywhere is chronic disease and access to appropriate health care. So one of the things that we're on the cusp of doing is establishing a hypertension clinic, or actually we're looking at two sites, one down in Miller County and one in Terrell County. Terrell County doesn't even have a hospital. Out of the 14 counties in our district, we have 4 that have no hospitals. And we have only about 6 or 7 counties that deliver babies. But in Terrell County, they have almost nothing except for some outpatient services. And there are a lot of people there who don't have access, who have hypertension. So what we're planning to do, hopefully in the next few months, is using telemedicine to establish hypertension clinics that will work similar to that travel vaccine clinic that I just mentioned. So we'll be able to provide basic medical care because of the technology. And this might be a good place to ask Salima to chime in and talk about it from the technology angle.
Thank you. So for us, telemedicine through a public health lens is really more connecting the dots and keeping resources local. So when we're looking at increasing access to care, for us, we know that public health departments, as looking in the map, 99% of them are all centrally located in your counties. So everybody, for the most part, knows where your county health department is. It's either on a bus route, it's in a walking route, it's near your convenience store, it's near your county buildings. They're centrally located in the county. So for us, we thought if we're already there and people are coming to us for some of these services, whether it be immunizations, TB, flu shots, routine women's health care services, how can we be that linkage to care? We do a great job of that with our CMS, Children's Medical Services Program. So children come in, they're diagnosed, assessed, and then they're referred out for specialty services. But what we started finding, like Dr. Ruiz mentioned, in our women's health, but in our children's services, is that public health gives you a great referral. At no cost to you, we will connect you to where you need to go. But in your rural counties, most of those patients were not going to those appointments because they can't get there. So for us, it was one of those no-brainers. How can we leverage the technology that we currently have, the infrastructure we currently have in our county health departments, where these mothers are already bringing their children in for services, and link them to those resources without them physically having to drive to get there? We knew that an endocrinologist or a pulmonologist for anybody in that Albany Health District or in Valdosta, let's say in that southwest health district, have to drive about 4.5 hours to get to their pulmonologist, which is most likely at Children's Healthcare of Atlanta. We know that our populations can't do that. They can't get there if they have to go every other week, even if they have to go weekly. Some of these kids with their pulmonology medications require them to be seen by their doctor weekly to check their doses initially, sometimes biweekly. So we thought, we already have partnerships with those county health departments. Our public health nurses are already seeing these patients and providing a referral. Let's make sure they actually use that referral. So let's utilize telemedicine to bring that value added and connect them to that referral provider without the inconvenience of transportation, leaving time from the office, trying to take off work, scheduling childcare. A good example of the childcare example is kind of what Dr. Ruiz was talking about with the Women's Health Centering Pregnancy Program. What he didn't mention is that program also went out of their way and looked for additional grant funding to provide childcare for those women. This may not be their first pregnancy. This may be their third, their fourth, or their fifth pregnancy. And trying to go to an OB appointment, already confused, already out of sorts, trying to corral all 3 or 4 of your additional children, trying to find childcare and transportation for them, it's probably why they're not going to those appointments. So what the Centering Pregnancy model did is it's more of a build the capacity within your own community and encourage each other to attend these appointments. So while you're at it, find your trust circle of 10, 15 other women going. Ask each other to carpool. If you can carpool to get there together, when you get there, bring all your children because we'll have childcare right there available for you during that 45-minute session so that you don't miss your appointments. With the value added of the telemedicine piece, again, you don't have to go see your maternal fetal medicine specialist and drive to Atlanta to get there. We'll connect you virtually. In addition to that, if you're having any mental health conditions or you need to speak to someone else, we can go ahead and connect you during those sessions virtually to another provider as well for that counseling that you may need. So for us, telemedicine was really that added value, as I've mentioned several times, and linking to providers within your catch area. If there's no providers within your region, within your district, we look into neighboring districts. If we can't find providers in your neighboring district, then we spread them out throughout the state. So what you often find in our DPH telemedicine programs is if you're south of the state, we're connecting you providers South Georgia and or maybe borderline Tallahassee, Jacksonville, because we know that's where your provider's already going to be. So for example, in Waycross, most of their providers for pediatric services are University of Florida, Jacksonville. If you're in Valdosta, you're probably connecting to someone at Tallahassee Memorial because they cover both states and those providers are licensed in both states. So even if you have to have that initial consultation in person, then we still make sure that you can actually quickly get there realistically instead of asking you to drive 5 hours to come to Atlanta. Same for VDOT. Think about VDOT. We mentioned kind of just the transportation and someone having to physically go into your community to provide somebody their medication and watch them take it. It is just that. We physically have to, imagine yourself driving in the car. Your job is from Monday through Friday, 8 to 5, sometimes 6 a.m. to 6 p.m., sometimes 10 p.m. at night, to get in your car as a public health clerk or nurse and drive to someone's house to give them 2 pills and say, open your mouth, take this, swallow it, open your mouth, let me see you swallow it. Get back in your car and drive to the next 25 houses to make those people do that. It is required for them to take their meds, and our staff have to do that. And it's taken us years to get to this place in this past year where we now allow them to do that virtually. So it's kind of a home health-based model utilizing telemedicine where patients can use their smartphones now. Imagine a truck driver. How can we travel and track down a truck driver who travels the country to make sure they're taking their meds? Adherence was not there. There was no way of monitoring that. So now we can say, hey, truck driver, do you have a smartphone, a tablet? What do you have? How can we connect you? We send them a link, kind of like a calendar appointment and or a web link. They click on it one time. We can do it daily, weekly, however needed, depending on their medication. They connect at the time that they've stipulated that they'll be available. And our staff from the health department or from their offices can connect with that patient, watch them take their meds, open your mouth, close your mouth, all in real time, and we can move on. Also allowing us to see more patients, save time on cost, reduce travel time, while increasing adherence. So that is kind of one of the first few models that we're utilizing from a testing of a home-based model. We're also looking this past year Open some codes for us for speech therapy and physical therapy for children's services. And we have our first telemedicine model via home-based services for speech and physical therapy that we'll be piloting this year. It's already started. It's in South Georgia. We're doing it in the South Health District, in the Southeast, which is Waycross. We've expanded just recently to the South Health District, which is Valdosta, and we're looking to move it into the Dublin District as well. But we're really going to look at health outcomes, adherence, and looking also at the broadband connectivity in some of these rural areas, because we know when we're implementing into the home, connectivity for us is going to be the biggest issue. So for us, it's really capturing that audience, saying if we were to do this in your home, affording you the opportunity to do it even closer than coming into your local health department, what does that really look like? Because we know in the metro area, it's going to be a breeze. But looking in some of your rural communities, connectivity, utilizing your own home internet service provider and connecting on our HIPAA compliant network, we want to see what that broadband quality is going to look like and that internet connectivity. And if I'm going to see a choppy person jumping up and down, I won't be able to see what those kids are really doing as movement and their speech, or if I'm going to have a clear connection in someone's home using their laptop or their smartphone. So those are just a couple methods of how we're utilizing telemedicine. A really new innovative one I want to mention before I pass it over to Dr. Ruiz is really our Project Echo model. And I'm not sure if many of you have heard of Project Echo, but it's a telemedicine-like model, more just like video conferencing escalated and elevated, where telemedicine is provider or specialist to patient. Project Echo is specialist to many, so one to many. So me, as a Project Echo model, I would be leading a conversation on a web-based platform to various providers on a specific subject. So for example, we have our first infectious disease Project Echo. We look to expand into opioid and maternal health and maternal mortality. So for us, it's myself, Dr. Felzine, our infectious disease doctor at the state office, presenting out to rural physicians, rural public health nurses, rural federally qualified health centers, rural institutions and universities and academia who are interested in learning about proper case management of infectious disease, complicated cases of patients for HIV, talking about discussion around PrEP, the new prescription PrEP medication, etc. So really, the goal for Project Echo is to increase capacity in rural communities and in hard-to-reach areas via video conferencing, so peer-to-peer. During these Echo sessions, we have a topic of conversation. These sessions right now are currently monthly, once a month, the second Thursday of every month for 1 hour. It's from 12 to 1. And during that 1 hour block, the first 30 minutes are a topic of conversation that's been submitted by the peers, everyone on that Echo panel. Tell us your hot topics, we'll build a calendar out for the entire year. We talk about that topic for the first 30 minutes. After that, we become going into a didactic, where we look and people from different districts, counties, public health nurses, and hospitals submit cases. And during that didactic, we sit down and look at that case, de-identified patient information, and talk about the model of care. What did you do? What did you do wrong? What could you have done differently? What questions did you have about this patient that you might not have been able to answer that you needed to refer them to a specialist? And our ID doc goes in there and has that conversation and asks those tough questions. At the same time, other nurses from other sites might be able to say, hey, I had a similar case. Hey, we did this differently. Hey, we thought about this. Did you consider X? So that's how the conversation goes. It's a forum for you to allow 30 to 45 minutes of your time to have a conversation have available to you in your community. For us, the return on investment is really building capacity in rural communities and in access areas where you don't have access to those specialists. So everyone becomes a subject matter expert. Everyone becomes a champion in your community. And you can leverage the technology to say, I may not have that answer, but I can find someone who does. In addition to that, public health partners with other entities and universities, hospital systems to integrate our telemedicine platform. We work very closely with Emory, Augusta University, other universities. We also work with the Global Partnership for Telehealth, the Georgia Partnership for Telehealth, so that our sites can connect to their sites so that everyone has access to receive the same education and messaging on our platform. If we have a provider that we know our patients need and we don't have access to them, Dr. Ruiz's staff will call and say, Sulema, I need access to an endocrinologist, a pediatric neurosurgeon. If we don't have one in our existing DPH contract services for providers, then I'm reaching out to my partners at the Global Partnership for Telehealth and saying, hey, Rena, hey, Les, do you have a pediatric endocrinologist or a pediatric neurosurgeon in network who can provide telemedicine for my patient in Macon or in Gainesville? Yes, all right, we connect the dots, and then we connect our health department for that. So that's kind of just how we're increasing access to care by not only looking at patient services, but also looking at accelerating and expanding the scope and awareness of services through our providers and specialty services.
Okay, I just have a couple of more things to say and then I'll stop. And what I'd like to close with is to sort of highlight some things that I think state government has done really well for us in our efforts to provide good health services. One of them is the legislative raises that we have had in the last few years. It's really hard for us to compete in the job market. There are a lot of places where people can go and earn a good living. And so we struggle sometimes to attract and to retain folks. So we've had some raises to come our way, and that really helps us to keep quality staff working with us. Another thing is we lost Title X about 3 or 4 years ago, and so that greatly challenged us in providing family planning services. But we were able to get some state funds that really boosted our situation. And I wonder if you all can see what I've got in my hand, and beyond that, can you tell me what I'm holding? Exactly. That's right. Also known as a LARC, long-acting removable contraception. There are two types. One is IUD, the intrauterine device, and the other is the hormone implant. And this is one of those. It's a little flimsy device about the size of a matchstick. It contains a very small amount of hormone, and it is inserted into the arm of a patient just beneath the skin. The procedure takes about 12 seconds to get it in there. It takes a few minutes to clean the skin and inject a little bit of Novocaine in there. But then it goes in and it stays for 3 years, and 90% of the time it's well tolerated and it works like a charm. The success rate approaches 100%. And so we are able to provide this service in every health department in Southwest Georgia, and probably every health department throughout the state. So this is just one thing that we're doing to help people plan their pregnancies, because that's very important. Pregnancies that come too close together or that come just at inopportune times have a way of disrupting the tranquility of a home, and it causes economic challenges. And again, it has something to do with that early brain development. When pregnancies are planned and spaced appropriately, you're going to have healthier pregnancies and better outcomes. So this is one thing that really works good for us, and we appreciate that kind of support.
Okay, we got some committee questions. I have one too. Representative Bentley. Pardon me? Don't get us started.
I have a pair of scissors for that.
No, we've already had the suggestion. You can hold that thing between your legs too.
Well,
Miss Patty,
that was interesting.
Elevate our conversation, please.
Thank you, Mr. Chairman. I forgot my question. But thank you for your presentation. That little gadget that you have, did I understand you to say that can be inserted through at the local health department?
Yes, ma'am.
And it stays under your arm for 3 years?
Yes, ma'am.
And it's going to prevent...
Here's a here's a model you can feel right there, and this is very similar to what it feels like once it's under the skin. Oh, a great question. On the street, the device itself probably costs in the neighborhood of in the regular marketplace. It will cost about $400 to $500, and then the provider, will charge a fee to insert it, and that's fair. But in public health, people with Medicaid, there's no charge whatsoever. People with insurance usually pay very little, and people who don't have a third-party payer and who can't afford, we have a sliding scale. So oftentimes, they will pay $25 for a device that will last 3 years. The intrauterine device, there are several kinds of those, and they will last up to 10 years. And the pricing is similar.
The health department actually does this, right?
Well,
Only the nurse?
Well, nurses in the health departments, because of the protocols that we have, they are able to provide things like long-acting hormone shots, known as Depo-Provera. They can provide oral contraceptive pills, but this requires a higher level, a nurse practitioner, a PA, or a physician to insert these.
So every health department has a nurse practitioner?
Well, in Southwest Georgia, we don't have a nurse practitioner for every health department, but they ride a circuit.
Okay.
And so we don't offer this every day in every health department.
Gotcha, okay.
But we have three, and I myself do this on occasion, especially back before we had a full staff. And I'm still available to do it, you know, if someone's out with illness or whatever. So currently in our district, we have a total of 4 of us who can put these in and take them out.
Okay. Thank you.
Okay.
You can contact your health department to figure out what schedule they're on and what clinics that's actually
Yes.
available, but it is available through your health department.
Gotcha. Thank you.
Yes, yes. And in some cases, a lady like wants one pretty quickly, and they're willing to drive to another county if they have that, you know, the means of transportation. So we do what we can when a patient says they want one, we bend over backwards to accommodate them.
Got a couple quick questions. Can y'all provide those to local OBs if they were to waive their fees? Is that an arrangement that could be negotiated, or?
Oh, to provide the devices to them?
Mhm.
Oh, my goodness, that would be above my pay grade. I don't know if that's possible or not.
Okay. The next thing is, I know yesterday we heard several of our medical educational institutions talk about working with you guys, and y'all providing more care in the rural areas. And I was just curious, do you have those conversations with them? Do they talk to you about how they can work with you guys in the district to provide more services and utilize students and different things like that?
We have had some of those conversations. I know Dr. Patton was here yesterday, and he's with the Medical College of Georgia. And in fact, he and I have had some recent conversations. I mentioned to him the fact that one of our problems in controlling tuberculosis, not just in our district, but probably in a lot of places, is that the diagnosis tends to be made a little bit later than we would like. Oftentimes when someone's diagnosed with active tuberculosis, if you get the history, they'll tell you, well, I went here and I got a diagnosis of bronchitis and I got a prescription. And then 3 months before that, I had the same thing. And typically commonly it's maybe 6 to 8 months that they've been ill before somebody kind of finally realizes, you know, let's get a chest x-ray and let's check it out. So we had a conversation about my recollection that in medical school I didn't get a lot of exposure to, that's the wrong word, but I didn't get a lot of experience with the diagnosis of tuberculosis. And I think that's probably pretty common. And so he and I were talking about ways that we could try to ensure that the medical students get some experience with public health so they can see more about how tuberculosis can be diagnosed quicker and how it can be managed better. We talked about rabies control, same thing. A lot of students don't get a lot of exposure in that regard. So yes, we've had some conversations, and I would love to collaborate with medical schools and training programs more than we do.
Okay.
Telemedicine perspective. From a telemedicine perspective, public health has been going to different universities and partnering with GPT and other agencies to make sure that students, when they're going through their classes, that they are receiving a class or at least education on what telemedicine is, how telemedicine is being utilized in rural communities, and how you can leverage this platform when seeing patients. So we are going into a lot of the schools and universities and some of the hospital systems to have those conversations and say, would you like us to present to one of your classes? Can we do a demonstration? We encourage you to reach out to a public health department site to see if they can come in and do telemedicine rounds and or at least see what a telemedicine session looks like from a public health perspective. So yes, we have had those conversations and continue to do so. We're also trying to see if we can work with the Office of Innovation and the Center for Innovation, as well as our GPT partners, to see if we can do a formalized curriculum to have available for telemedicine services. Like here, we know that there is a virtual telemedicine presentation. How do you present a patient? How do you see that we're provided already? But to see if there's an actual model where they can come in and do a full curriculum and course on telemedicine practice and protocol.
Okay, well, if there's anything that you think, that y'all think of that we can help encourage those relationships where we can have more of that conversation, because they all seem to think y'all are a great avenue to get to these communities that don't have hospitals. So just please let us know if there's anything we can do.
And while you've got the microphone, I have a question. You know, are there any rules or regulations that really hold telemedicine back? I mean, I think it's a question we often ask in this committee is what's holding you back, what's something we can do to make it better? And do you have any suggestions?
Sure. Well, last year I would have had a lot of comments on that, but this year I think with the new legislation passing of allowing outside providers to provide telemedicine and receive a telemedicine license, I think will be super beneficial. For us, we have this great platform, we have this technology now, but we still don't have enough providers to see these patients. So maybe increasing providers, I can't wait to see what that new bill will do and if it will open the doors for a lot more services and more patients to be seen. I also think it's really beneficial, and I'm waiting to see what the bill will look like with legislation now allowing for telemedicine to be billed at the same rate as an regular office visit. For me, that's something I would have said has been a barrier, is that reimbursement rate, because providers aren't willing to see patients via telemedicine because it's at a lower cost. So this year, as I'm recruiting providers, I want to be able to say, hey, there's a new bill that's going to allow you to bill at the same rate as an in-person visit. Will you now consider telemedicine to see these patients? And I'm hopeful that that will make a difference. If not, that's going to be my grunt there. My pain.
So you made that reference to somebody, let's say in Southwest Georgia, needing to go to children's health care. Do they have to, is there a barrier where they have to go there one time to see the physician, or can the whole thing from beginning to end be done via telehealth?
So for us, I say public health is kind of special and unique in that sense. We kind of benefit from the fact that public health is exempt from that initial consultation needing to be in person. So for a public health, we're able to see a patient the first time and immediately start a telemedicine session if necessary. That's not afforded to every other organization and every other originating site. That is something that public health has an exemption for. So for us, yes, you can come in, we can see you. If we have a specialist and we have a clinic that day for telemedicine, we could connect that patient as long as every effort is made to have a medical history on the spot. Our best practice is, though, that initial visit be in person, and most of the time the physician prefers that, and then all follow-up care is done via telemedicine.
Okay. I've got one here. Jim Williams.
On the child delivery that you're speaking of in rural Georgia, I hear there's a discussion of midwives being utilized more and more. Is that something that's possible that might be looked at?
And I think I'm correct in saying this. In public health, I don't think we employ any midwives. I don't think we have any direct connection. But in Southwest Georgia, we have quite a few midwives. And in fact, we have worked with a few of them a good bit, encouraging them to consider using these devices, particularly immediately after delivery. And so our district already relies on midwives. And we think it's a great way to provide health care, and we would be happy to know that we had more qualified midwives coming into our district.
Great, thank you.
Chairman Cooper.
Can I just add really quick, though, one of the questions about broadband, barriers, I still think it's affordability to broadband and internet-based services. I know there's a lot of conversation and discussion around that, But looking at rural hospitals, small county health departments, and the cost for us to man and support the infrastructure to have dedicated circuits in county health departments, or to increase the broadband capacity and the internet capacity in our clinics to provide this service is very expensive. And I know we do receive a legislative appropriation for telemedicine, and that's what's been able to leverage us getting this technology in place. But I would love to see more of that funding not be utilized just to pay for circuit cost and infrastructure, and actually be used for implementation of programmatic services. And the cost right now for broadband and internet in some of these smaller communities is still ridiculously high. So again, we're trying to do home-based stuff, but also just for people to be able to provide internet access in their home, it's too expensive. Sorry.
Okay. As far as barriers, I know that the Board of Medicine, as like we deal with all boards on their various issues, are looking at the telemedicine rules and could present a barrier, but if needed, I'll be going to the board meeting to discuss how we don't need to have, real barriers to telemedicine, okay, coming up. But I know there's some discussion of some things that might cause a problem for not public health, because it is different and has exemptions, but just in general use of that. And to the answer about midwives, nurse midwives don't deliver babies on a regular basis, but there is a new midwifery school coming. It's in the very beginning stages through the regions. It will be in a more rural university setting, and I am asking that they look at a different kind of program, that maybe they do it like an MBA, where nurses already working out in the rural areas might be able to, work 4 days a week and then take advantage of the experience they need to become a nurse midwife by traveling to that area. So we are working on that, where there could be where you have your obstetrician in an area, but the nurse midwives do the prenatal care and all the kind of care that people need, and then work with the physicians in those areas. So there are hopefully more nurse midwives coming.
Thank y'all. We need to move on, but thank you very much. We appreciate it. Okay, next we've got a rural physician shortage panel. We look forward to hearing from them. We've heard this a number of times in the last few days, and we look to hear some solutions these fine folks have for us. Derek, are you the leader of this fine group?
I hope that they're not relying on me to be the leader. We're going to have Stephanie Kendrigan go first, Government Affairs Director for MagMutual, and then I'll make a few brief comments and then introduce Dr. Bolke from Brooklet. So I know that we're over the time that y'all have allotted, but we're going to be brief and try to catch y'all up.
You have an important subject we'd like to hear.
Well, thank you for having us today. Again, I'm Stephanie Kendrigan. I'm Director of Government Affairs for MagMutual Insurance Company. We are domiciled here in Georgia and Atlanta. We were actually started in Georgia in 1982. We are now the largest medical malpractice insurer in the state of Georgia, but we're also the 7th largest in the United States. A lot of people don't realize that we write in other states. We're in about 30 states now across the U.S. And so I want to talk to you a little bit about today about the rural physician shortage. And I know probably some of you are wondering, why on earth is a med mal insurer worried about the rural physician shortage? And what we've really seen is there is a lot of data, and compelling data really, that shows that a state's legal environment, as well as the med mal premiums in that state, can help, is actually tied to your physician recruitment and retention. Just in the underwriting process alone for rural healthcare physicians, it's kind of a dire impact. And here's why I would say that. When you are out in the rural areas, let's just say that you are a general practitioner in Southwest Georgia. We'll just use the region we were already talking about earlier. Unfortunately for you, you might think, oh, my premium will be lower in Southwest Georgia than it's going to be in Metro Atlanta. Well, that's not necessarily the case, and here's the reason why. you are suddenly treating more and more patients every single day. Well, guess what that does? That's going to drive up your premium because you have more exposure. You're also treating different kinds of patients. It's not just, adults that are coming in all of the time. You're going to have some pediatric visits. Guess what that's doing? That's driving up your premium. You're also going to have OBGYN visits. Guess what that's doing? Driving up your premium a lot. So just by being in a rural setting and being a general practitioner, you are already going to have higher rates than your counterparts in the metro areas. Where those pediatric services or OBGYN services are readily available. The other thing that ties into the underwriting process when we're looking at med-mal premiums is actually a state's legal environment. So unfortunately for Georgia, this is where we are woefully behind in the Southeast. We now have the worst legal environment for physicians specifically in the entire southeastern United States. And so when you compare us to other states, let's take North Carolina. And North Carolina is a great example to compare us to because not only are they similar in just the population size, the rural-urban setting that they have, I mean, even the geography. They have a coast all the way up to the mountains, right? So it's a very apt state for us to compare Georgia to. If you were an OBGYN coming out of med school and you've got $250,000 in debt, it's going to automatically cost you 52% more to get your med-mal insurance in Georgia than it would in North Carolina. If you are a general surgeon, it's going to cost you 56% more, and if you're in internal medicine, it's going to be 49% more. That's $20,000 to $30,000 more a year that you are automatically losing because you went to Lumber City, Georgia, instead of Lumberton, North Carolina, right? So that's not a good situation to be in. And so that obviously makes it harder for us to recruit new grads. But then if you're also a physician that's practicing here and you're looking, well, I can practice that much cheaper in a neighboring state, heck yeah, I'll move there, right? The other thing that we're seeing, so what's driving that higher rate, right? So why is it so bad in Georgia compared to in North Carolina? So I mentioned that we are now the worst state in the Southeast for physicians in terms of our legal environment. That ranking is actually, we're the number 9 in terms of severity. So just to put that in perspective, severity in the insurance world is what we pay out per claim. So when a claim comes in the door, the average severity is what we typically pay back out. Georgia is now 9th in the United States. We're sandwiched between Massachusetts and New Jersey. All right, this is not a good place to be. Illinois is number 1, but we're close on their tracks at this point. If you look at North Carolina, who we just compared Georgia to, they're 35th. So there's a reason they have lower rates there, right? We've also seen increases in our severity over the last 5 years of 46%. All right, so the average payout in Georgia is now $500,000 if a claim comes in the door. $500,000, right? The problem with that is not only is that a higher number than all of your neighboring states, so North Carolina is about $250,000, is we also have increased frequency in Georgia, right? So not only is it higher, we're seeing it more and more and more and more and more. So over the last 3 years alone in Georgia, the number of paid claims has increased 47%. 47%. Now this is nationwide, the number of paid claims has steadily decreased, and that makes sense. You have better patient safety. You have better technology. So you've seen the number of paid claims trend downward nationwide, but they've increased 46% in the state of Georgia. So you add all of that together, just the aggregate severity in Georgia is increasingly higher. And then you factor in what we're seeing now with some of these massive verdicts. So there have been record-setting verdicts in the last 5 years in Georgia. You're seeing a $46 million verdict. Just last week, there was an $11 million verdict in DeKalb County. So what it does is it continues to drive up the med-mal premiums in the state of Georgia. So let's do another case study. I love to compare Georgia to some other states. So some of you were actually around in 2005 when tort reform was passed here. I know Butch was here. Representative Cooper, you were around. Representative Green. So Georgia passed tort reform in 2005. Right around that same time, Texas did a big tort reform package in 2003. The major difference here is that Texas still has effective tort reform. Everything that their legislature passed is still in law. Georgia, it all got undid by the courts. So pretty much everything that was in the 2005 package, Senate Bill 3, has been completely undone, with the biggest blow coming in 2010 when the caps were overturned. All right? So when you look at physician recruitment in Texas, for example, they now have 25, starting in 2003, that's our baseline, they have 25% more physicians in Texas than they would have had they not passed their legislation in 2003. And their medical board in Texas actually released some data earlier this year. They believe they have 12,000 more physicians in the state of Texas as a result of their actions in 2003 than they would have otherwise. We, on the other hand, continue to struggle to get any physicians to come, especially to rural areas. So that's kind of some of the, the highlights of where we are in the med-mal space and how that can impact, the rural physicians. And I'm happy to answer some questions later, but I'll pass it on down and let Dr. Bulkey talk about some other issues as well.
Well, thanks, everybody. I'm Derek Norton. I'm the Government Affairs Director for the Medical Association of Georgia, and we're going to gain some time with me. I'm going to be brief. My role today is less of a presenter to this group and more of a handler for Dr. Bulkey. And I know in a few weeks, y'all are going to hear from me every day for 40 days anyway, and y'all would much rather hear from one of our MAG physicians. But I will say MAG remains focused on helping rural physicians. We advocate for Medicaid rate increases for primary care. We have a close relationship with the Georgia Board for Healthcare Workforce and worked with them on a variety of issues. We worked on and supported the preceptor tax credit this year. We continue to work to bolster rural county medical societies, which can help with retention and providing physicians more ties to the community. MAG has a task force focused on rural health care and recruiting and retaining physicians, and that task force is always available to help as legislation goes forward. And then we're laser focused this year on improving the deteriorating legal climate in the state, which creates a lot of barriers for rural physicians to practice. And with that, I'll introduce Dr. Bulkey. Dr. Bulkey is a graduate of the University of Georgia, went to the graduate of the Medical College of Georgia, did his residency in Columbus. He's a board-certified family practice physician out of Brooklet, and is a past president of the Medical Association of Georgia, and is the current Council on Legislation chair at MAG. So he's the perfect example of somebody who went to school here, was trained here, and stayed here, and practices in a rural setting. So with that, Dr. Bulkey.
Thank you. I'm gonna stand because I work better standing, because that's how I am in my office. But Butch probably is the only one that knows where Brooklet, Georgia is, because when you're from a small town, you go by the county, right? I'm Bullitt County. He's Emmanuel County. Representative Hatchett's Lawrence County, right? So when you're from a small town, you don't say the town because nobody knows where that town is. You go by the county. I actually was born and raised in the capital of South Georgia, which is Jacksonville, Florida. And by the way, it was a great game a couple weeks ago when we beat Florida down there, because I went to the University of Georgia. But I was heavily influenced by a physician that was in Nahunta and Folkestone, Georgia. Now, that's on the border down there, southeast Georgia, way down there, right? That was before Kings Bay, the naval station and all that stuff. Since then, it's completely exploded. But back then, there was not much there. I saw what he did. He was in one office in the morning and another office in the afternoon. And he flip-flopped it the next day and drove 100 miles an hour to get to these places, and the sheriffs and everything just kind of waving them through. They knew Doc was coming, and he was going to take care of folks. So I was very, very heavily influenced, and I bring that up because you heard yesterday, I saw on your agenda the medical schools who are trying to get physicians out there, trying to get the 3-in-3 program from the Medical College of Georgia, to get people out there. That is so, so important to get physicians, and I'm a physician, I'm sorry, I'm not a provider, but I'm a physician, into these rural areas, okay? The more that they are exposed there, the better chance that they actually will go there, okay? It's all, American Academy of Family Physicians put a white paper out 2 years ago, I believe, and the physicians, the medical students who come from rural areas tend to go to rural areas when they graduate, when they go through the residency. more family physicians, and that's what I am, a little biased here, but more family physicians will go to rural areas than an internist. I think 45% of all visits in rural areas are done by family physicians, and only about 2 to 3% are done by general internists. Most internal medicine physicians then specialize, become pulmonologists, gastroenterologists, cardiologists, so forth and so on. So it's very, very important in the recruitment of physicians to have that. I applaud Mercer's always been a school that's been supposed to get into rural, physicians in a rural area. Funny story there, I was actually put on their waiting list because I got into MCG and not into Mercer because they didn't think I was serious about going to a small town. A friend of mine who was from Wrightsville, Georgia, was the quarterback for Herschel Walker, got into Mercer. He's a pediatric neurosurgeon in Greenville, South Carolina. So it doesn't always happen. They don't always get it right. But it's a chance to increase your odds to get people to go to these areas, okay? The exposure in residency, doing residency and doing a rotation in a rural setting, wow, that's important too as well, because that brings that exposure. Hey, I may want to, and when I get done with my residency, I may want to come here. Now, I'm also on the Georgia Board for Healthcare Workforce, and Representative Hatchett goes to most of these meetings. His brother is an OBGYN also on the board from North Georgia. And our job is actually to try to encourage people to go to these areas. We have a loan payback up to $25,000 for up to 4 years for physicians to go to these areas. So that's a pretty good chunk of when most medical students are coming out with, I think the average is almost $300,000 in student debt. I took out loans when I went to med school, and I spent 4 years in the Air Force to pay for my medical school, okay? There's no way. And 1 year in Brooklet, I bought a practice, bought a building, and renovated a building, and I was in more debt than I'd ever been before. And the sad thing, or the interesting part about me, was my bank's right across the street. And they'd make sure I'd get up every morning and go to work, so I'd pay that loan off, because that was a hefty loan. But they believed in me and trusted me, and I guess I was a good bet for them to be able to loan that. And then here I am, it's 21 years, going on 21 years. Now, my office has been there since 1956. So it's the longest acting practice in the Bullitt County for over 60 years. When I got there in 1999, the physician, Dr. Bowler, who, no relation to me, still had his medical records on 5x7 cards. All right? I went from 5x7 cards to a regular chart to an EMR all in about 3 years. I think I probably forced him to quit because we did all that. But I look back on those notes, 1972, Mrs. Jones, pneumonia, penicillin. That was the note. Now I give a dissertation. Y'all seen your notes probably when you go into the ER. You go to the ER, see those notes? 4 or 5 pages long, and about 5 lines are actually probably pertinent. It's sad that what we have to do that. And that's a barrier for getting folks out there, all in healthcare, but especially in rural areas. So also, I want to retain physicians in the rural areas. Here's the biggest thing that you'll have to find. I'm on hospital board. I'm on Rotary. I'm on the Kiwanis Church. You're involved in the community socially. And if you're not a physician, male or female, doesn't really matter, that's not wants to get involved in that community, that's going to be a tough pull. Those people probably won't stay in that community too much longer, right? I don't go into my Walmart. We only have one Walmart in Statesboro, right? I don't go in there. My poor wife has to go in there, okay? Because I see too many patients there, and they want to ask, hey, what's this, what's that? You hate to be rude. It's not the time to be discussing. There's a HIPAA violation, right? There's all kinds of things that can mess up. That's not the spot to do that. You try to be nice and say, well, no, I don't know. You need to come to the office, right? But that's difficult in your small town because you see them constantly. So I don't go into the Walmart. I'm sorry. So I just don't. But those are issues there that a physician, once again, male or female, has to know, and exposing them in those settings, and knowing if I had a student with me or a resident with me and I go in these areas, they'd understand, hey, there's doc, there's da-da-da-da. He has to understand, he or she would understand all that goes into being a physician in a rural area. And that's, a lot of people don't talk about that, but that's very, very important, because if they're not comfortable with that, they will not stay there. We do all these physician loan back, they stay there 4 years, 3 years, 4 years, and then they're gone, right? There's a lot of J-1 visa folks that have to go somewhere for 3 or 4 years, and then they're gone. It's good that they're there for the time, but unfortunately it's not very good that they stay and leave, because then you got to get somebody else to take their place, and that's very, very difficult, especially. The number one reason, I found this kind of amazing, the number one reason that a physician will choose to go, the biggest reason they don't go to a rural area is their spouse or their significant other. Okay? When I was looking to go, my wife said, nope, we're not going there. Okay, guess we're not going there. All right, that's important. And now, if both are working, that significant other or spouse has to have a job too. And that's important. Okay, so those are issues that I know with all you legislators, heard the rural broadband, you heard all the virtual things that are going on. If you don't have a good internet connection, that's horrible. I've been very fortunate in my little town of Brooklet. My telephone cooperative has had a great internet service since I've been there, which is just absolutely, I've been blessed in that regard. That part is so important. I just saw somebody speak the other day that, do you know that Alexa, how many people have an Alexa in their room? Do you know that's now HIPAA compliant? It's always listening to you, and the hope is Amazon at your home, and think of that, if you were wheezing and Alexa hears you wheezing, they could call the ambulance, they could call the doctor, they can call. This is where all this is going, okay? So internet is important. I'm a little conspiracy there. I don't have an Alexa. I turn my Siri off on my phone. I don't want people listening to me. But this is where all this is going, okay? As I was once told, if money's the answer, what's the question? So to help physicians in the rural areas, it's about payment, right? I'm in Medicare, and I know we're in the state, but Medicare, I'm in designation 99. Right? The greater Atlanta area is a designation of 1. What does that mean? They get paid more from Medicare. Why? Because they're in Atlanta. Why? Well, because we think it costs more in Atlanta. Okay, but there's a lot more resources in Atlanta. I don't have all those resources in my area, right? We have one dietitian in Bullitt County. So and Lord knows I got plenty of diabetics. How do I get one dietitian to talk to all these diabetics? So it's an issue there. In the state level, obviously it's Medicaid. Obviously that's important. Trying to increase those reimbursements for folks, that helps gets people to go out there, because the perception is, gee doc, you're out here in the middle of nowhere in the hinterlands, you don't make a good living, I can't pay my student debts off, so I'm going elsewhere. Or I'm going to specialize. I'm going to be this great cardiologist that does caths on everybody and makes lots of money. Okay? So that's important. If you don't think it is, you're sadly mistaken, but that is vitally important for the folks coming out. When you got $300,000 in student debt, how long is that going to take you to pay that off if you're not making a decent living? Especially as a physician and in a rural area. I could talk hours about this, and there's one caveat to the tort reform. We had a young general surgeon, who was actually younger than me, that came to Statesboro, which is my town about 10 miles away. We had 4 general surgeons at that time. He got sued. The plaintiff's attorneys, the plaintiff's special witness said that normal saline, if all in the medical field know that normal saline is not supposed to be used for trauma resuscitation, which is IV fluids that we all use. I've used them since whenever, okay? Physician won the case, had to move. It was all in the paper. I had patients come in my office and say, well, yeah, Mr. Jones, you have to have your gallbladder taken out. Well, that's fine. Just send me anywhere but that physician. Wow. He ended up going to Fitzgerald, Georgia, from Statesboro, and we were down to 2 general surgeons. It's a 150-bed hospital, not a small hospital, but not a huge hospital, but general surgeons are kind of a backbone of a hospital. They do all the stuff that needs to be done, whether it's do the surgery, do the central IVs, all the things that they do. They are vital, vital, vital. We're down 2. We just got 1 coming in, so we're up to 3 now in Statesboro. So that is, can't impress how important those kind of things, because that what got me involved into the Medical Association and various other things to do that was because of that lawsuit. He lost, but yet, I mean, he won the suit, but yet he lost. And that's just a shame. He was a fine surgeon, and it was sad to see him go. From the Georgia Board for Healthcare Workforce, there's 8 counties in the state of Georgia that do not have a physician. Period. 8 counties. There's 11, I believe, 11 counties that don't have a family physician. 63 that do not have a pediatric, and 75 that do not have an OBGYN. Now, it's tough to get an OBGYN to go to an area where a hospital where there's no hospital, or there's a hospital that doesn't deliver, right? It's kind of tough for an OB to go there. So of the recent law that y'all know that passed, that we changed our underserved area from 35,000 to 50,000. Now there's 159 counties. There's only about 30 counties or so. I may be wrong on the exact number, but there's about 30 counties that are not 50,000 or under. Okay? My county in Bullitt County is 70,000. But 20 of those are called Georgia Southern students. And Bullitt County, land-wise, is the 8th largest in the state. So we're big, spread out, and I would tell you I've got some rural, and Butch would know because part of his district is touching on that west side of Bullitt County, is as rural as there are. So I say that because that's the program that the Georgia Board's doing is a great thing. They have great data. It's on their website, and I know they do a great job. I know I see back in the back the Philadelphia College of PCOM, right, has got a new med school going down in Moultrie. So those are the things that needs to be done to get folks out into the rural areas, get those physicians trained, get them exposed. That is so very important. Once again, that initial exposure can go a long way. You can change a medical student's mind from from one thing and then go into rural medicine, and certainly doing primary care, which we are certainly lack of. I will stop. My practice, once again, we talk about access. I am a walk-in office. Matter of fact, I'm missing patients right now. But I'm walk-in. I have no appointments. You're sick, you come in. We'll see you. Right? When I took over the practice years ago, he never had an ending time. He opened 9 a.m., closed when the last one was seen. Okay? So I couldn't do that. Having to go to the hospital and everything else, but I'm a walk-in. We're so tied into appointments, and you're seeing all this virtual health. I got virtual visits. They want me to start doing virtual visits and everything. That's great. Happy to do it. But sometimes you still need to have a physician or somebody be seen, hands-on. It's an amazing concept when sometimes you actually listen to a patient, examine them, touch them. Still goes a long way sometimes without a lot of cost, because I'm not ordering CT scans and MRIs, which drive up the cost. But I will close there. I appreciate the opportunity to speak to you, and I hope I didn't overstay my time.
No. So we look around, Dominic.
On the topic there, Stephanie, with med-mal premiums, I heard very clearly what you were implying.
Right.
And just a little bit of it in what he was saying, but give us an an idea of some reforms that would help with that, to maybe level the playing field with someone like a North Carolina or Texas or whoever.
Okay, so, where Georgia's going to have a more difficult time is the fact that our caps have been ruled unconstitutional. So if you wanted to get caps back, which is probably the best tort form that's out there, right? You would have to do a constitutional amendment. I don't think that is feasible at all. But that being said, there are some very, what I would consider moderate reforms that could be made that would really help a lot in this area. The very first one is eliminating a thing called phantom damages, and I will just briefly share what this is. So when you go to a physician, and let's say I take my daughter to the pediatrician, she has an ear infection, we get a bill from our pediatrician for $135, but at the end of all of this, I actually paid $35. There was a $100 price differential between that. In our world, we would consider that a phantom damage. Now, let's put this on a much larger scale, right? I am driving, back to Atlanta tonight or this afternoon, and I am involved in a car wreck where I hit somebody. That person ends up going to the hospital. They undergo multiple surgeries. They get a hospital bill for $50,000. What they end up paying to that hospital or to their physician or whoever is $10,000 of that, right? So $40,000 of that is a phantom damage. In Georgia, we allow for the plaintiff's attorney to admit that billed amount into evidence rather than the amount that was actually paid. What that does is, in this case, it would result in a $40,000 windfall for the plaintiff and their attorney that was never actually incurred. Does that make sense? So now where that even gets exacerbated more, we're talking, so that was $40,000 in medical fees, right? Now imagine the jury's also going to come back and they're going to award the non-economic damages. So that's an economic damage. That's, I was out of work for this amount of time. I had to undergo these surgeries. What a jury will typically do is you will see them use a kind of a multiplying factor. So they'll take that $50,000 that they had for economic damages, and now they'll multiply it times 3 or 4, and they'll say, well, your award is, we're going to give you another $250,000 for your non-economic damages. Suddenly, that lawsuit is worth $300,000, whereas if it would have just been the $10,000 that they were basing it on for their actual paid medical expenses, you multiply that times 3 or 4, suddenly you're looking at a $50,000 verdict, or what should be a $50,000 settlement in that case, right? So you see how this gets really big really fast. So that's one of the places that we would like to see some reforms, is just to make it so that you can only sue for what was actually paid, not what was for billed. A second place for improvement, and Georgia is one of the only states where we can identify that allows this practice, is a practice called anchoring. So at the very end of a trial, and remember there's different types of damages, right? There's the economic, so that's what we're talking about, your medical bills, your lost time and wages, that sort of thing. There's also your non-economic damages. So this is going to be typically your pain and suffering that you might have. In most states, law requires that the jury comes back with what that non-economic damages be, right? The plaintiffs can submit like, well, this is, Billy made $15 an hour. He was out of work for 2 weeks. That's a pretty easy calculation that you can show, right? So they can show all those economic damages, or whiteboard them is what they call them. But then what Georgia allows is very unique in that a plaintiff's attorney can get up in their closing arguments and they can say, and for the pain and suffering, I think it's worth $26 million. Well, where the hell did they get that number? Sorry for my language, but where did they get that number, right? There was no calculation that went into that. They pulled it out of thin air. And what you typically see in most states, that type of testimony or closing argument would not be allowed whatsoever. That would result in a mistrial in a lot of states, because what you were doing is you were manipulating the jury into thinking that there's larger damages that should be awarded than what you should really be awarding. So you're essentially you're manipulating the jury. We actually saw this happen a few weeks ago where, again, this is the DeKalb County, this was a med-mal verdict where the plaintiff's attorney in his closing argument said, I think, this family's pain and suffering is worth $26 million. Well, the jury immediately came back and awarded $11 million. So, and all of that, it gets paid for somewhere. And it's the physicians of Georgia that are paying for those types of verdicts.
Chairman Powell, right here.
Stephanie.
Yes.
There was a series of articles in AJC not too long ago about the abysmal
record that the medical board has in disciplining negligent doctors. How much of the medical malpractice problem in Georgia is because we continue to allow negligent doctors to practice?
I think that's probably a little overinflated, quite honestly. What I would tell you is what's happening more and more is, yes, are there bad actors? Absolutely. I'm not suggesting that there are not some bad actors out there. Georgia actually doesn't require you to have med-mal insurance, so there are some physicians that are practicing that are not insured at all, right? So, a physician like that that's had multiple claims, we're not insuring, right? That's too much of a risk for us. And they're not, right. So I say all of this. So, the data that I have is what we're seeing internally. So I can only base it on the good docs that we are actually insuring. And so what's really driving up a lot of this cost is actually just the sheer number of claims that are coming in. And what's interesting about some of the claims that we have coming in now is it's things that you would have, in the recent past, you would have never seen a claim for, right? An example of this is we're starting to see more and more claims for a condition called shoulder dystocia. So when during the birthing process, the baby's too big, a shoulder just gets dislocated on its way out of the birth canal, right? This has been happening for thousands of years. Well, now we're seeing just case after case after case after case because everyone thinks that's going to be their chance to hit the jackpot on one of these cases, right? So it's more of I would say it's more of a legal climate than it is that you've got this handful of bad docs that's driving it up.
Is there anything that can be done legislatively to differentiate between true negligence and true malpractice versus a bad result? I mean, like 10% of whatever is going to, it's just going to happen. So how much of these things are bad results, and is there a way to legislate against awarding damages for bad results?
The best solution that you might have for that actually is something that North Carolina does. So in some of these cases, you'll have a bad outcome, right? But it wasn't necessarily bad medicine. And you will have a jury that is somewhat sympathetic to the bad outcome and thinks, oh, well, let's just give them a little bit of something, right? Well, that's still a finding against that doctor. They're having to report then to the National Practitioners Database and to the Georgia Composite Medical Board. So, but one of the things that North Carolina does, and this was very smart on their behalf, they thought, why don't we do a thing called trial bifurcation? So in a trial bifurcation, you only consider the negligence portion of that trial first. So you have the same judge, same jury. But the only thing that is discussed is whether or not good medicine was practiced. So the jury doesn't become distracted by, well, they had this amount in medical bills or this type of thing, and they can instead focus on, was this good medicine? If they find that that doctor was negligent, then they move into the damages piece of the trial. It's the same, again, same courtroom. I mean, they just keep going, right? But first, they have to focus solely on, was this good medicine, and they don't worry yet about the damages. I think that's probably, and North Carolina does that. That might be something that we should consider in Georgia to kind of weed out some of these cases where it was just a bad outcome, but good medicine was practiced.
Any others? I just had just one. We passed a bill or put money in the budget to subsidize these medical malpractice insurance premiums in rural areas. Derek, do you know how has that worked out, or has that?
Actually, it's part of the Georgia Board it's part of the Georgia Board of Healthcare Workforce. Actually, is part of the thing. I think it went enact last year, I believe.
Yeah.
One physician used it. Yeah.
Just one used it?
Just one used it.
He was the only one paying too much?
No, it's the only one. I guess it's relatively new. It's on our website. It's on their website, but only one person used it.
Okay.
Yeah, the word is not. Yeah,
Okay.
it's just starting. But to be frankly honest with you, you're talking about $1,000, $2,000. What would help me, real quick, is I'm an independent physician, so I'm not owned by anything.
Yeah.
My healthcare premiums. I have one exchange product in Bullitt County. It's going to be two here shortly, but one. for a family of 4 with a $10,000 deductible, started out at $400. They went to $800 a month, $1,200, $1,600. 2 years ago, it was $2,400. So it's $30,000 with a $10,000 deductible. It's $30,000 out of my pocket before insurance would cover. So there's a problem when the person who's helping to provide health care can't afford health care insurance.
I just have one other question for you, Doc. So on February 12th, when there's this giant line of people with flu, how do you handle that? You're a walk-in. I'm just curious. I mean, that's just me.
The most I ever saw one day was 105.
Wow.
And part of that, and I don't tell you that to amaze you. I tell you that because I know my damn patients, okay?
Yes, sir.
And I know when they're sick, and I know when they're not sick. And first thing when I have students come in, first thing I tell them when I look in, the complaint is a cold, flu, whatever, tell me, is the patient sick? Not sick. It's kind of like the bifurcation of the trial. Are they sick or not sick? The first thing when you look, it's the same thing with the infant. You can pretty much tell there's a thing called a social smile for an infant. If you can get the infant to smile, that's a good sign. And that's what happens. And a lot of physicians, unfortunately, a lot of them don't want to see that kind of volume. I see it because there's a need, because it's really needed, and folks like to see somebody that they know, and they go, ooh, because he'll let me know if I need to send you somewhere or whatever, I can help direct and do that. But that's the important thing for me, and that's why I went to where I went.
If I can ask, continue,
Yeah.
how many folks work in your practice?
So I have, I employ 10 people. Yeah. So I don't do a group health insurance, can't afford it.
Yeah.
I ask them to go get their own. I give them a monthly stipend to do that. But just for their individuals, not for their families. Thank God I got a couple that their spouses have insurance.
Sure.
Okay. But it is, that bill would be, and then malpractice premium. So you're talking about that kind of money before I open the door, January 2nd. So
Well, I asked that because I was just following up to my mind on what an economic engine a family practice physician is in the community.
So the Medical Association did that study a couple years ago through the University of Georgia. Actually did the study and did the thing. And what was a couple $1 million per community?
Yes, sir.
So I'm the second biggest employer in my little town.
Chairman Cooper.
Okay. Thank you, Dr. Bokey, and I apologize for asking you a medical question this morning.
You have good insurance? No?
I did come back and tell you that I just sent me a bill, didn't I? So I do apologize, but just to the group, I know a lot of the physicians in the state because of my position and because Tom was a physician. And Dr. Bokey's one of the best, and we really do owe our Dr. Bokey and our other physicians that work in our rural areas a great debt. And so thank you very much for all that you do for the patients in your area and all your involvement in the Medical Society and on the board of the Workforce Development. It's really important. Thank you very much.
All right, now for our last presenter. While he's coming up and while Holly's passing out some handouts, and we transition over.
Before we go on, could I correct something that I said before we have all the nurse midwives calling us and telling us I was wrong? Nurse midwives do deliver babies in hospitals in cooperation with physicians. They just don't deliver babies at home or out where there are no hospitals. So I wanted to make that clear. But they would be a great asset if we had more of them, because so many people, women, cannot get in for prenatal visits until they're way into the pregnancy. And if nurse practitioners were out in the communities where they could do those early visits and assessments, it would be a tremendous help in preventing complications. So I figured we were going to have people calling us to say nurse midwives do deliver babies, and they do, just not at home. Thank you.
Gotcha. All right, well, before I turn it over to Mr. Matney, I was just going to give a few brief comments on his behalf as well, and kind of update this body. If you're not familiar, you weren't here, in 2013, the General Assembly appropriated $300,000 to help the hospital and the South Georgia Consortium put together a family medicine residency program. And they took that $300,000 and they did that, and they have been successful. And I think they have currently up to 14 that have been through that program, and it worked. And they've got a lot of great things going on with that and their partnership with PCOM and all that they're doing down there. So he comes today to talk about something that's already been mentioned today with one of the earlier presenters in the rural psychiatric residency issue and trying to find more doctors to solve that problem. And of course, yesterday we heard about farmer suicide and being in South Georgia. Obviously, we have a lot of issues that we're going to need more and more and more. And I think they have a way to help with that. And that being said, too, I know the family medicine residency program has a regional impact. These are going to different hospitals across South Georgia. So I'll turn it over to you, and the floor is yours.
Thank you, Chairman Watson. Glad to be here today. A lot of things going on down in Mochi, Georgia. If I can figure this flipper out, which way do I point? You know, one of the things I'd like to point out is the fact we are a farming community. So we like to use the analogy that the fact that you helped plant the seed in rural South Georgia. I remember that day that Sam was talking about. In fact, he and I were talking about this week. I really had not been around a bunch of legislators before, and we were starting a family practice residency, and we went in Chairman Parrish's office, and I think Penny was there, and everybody was there, and we asked for some money. And Sam said, "You got anything about the program?" I said, "No, all I got is a vision right now." But we turned that vision into something that really has received both state and national recognition. A little bit of the timeline there. Can y'all hear me good, or do I need to be there? I can't. Okay. You can hold it though. Okay, let me, because I can't see this. I'm too old for that, for the small part. But you know, we started in 2000. We met with y'all in 14. You gave us money, and we got our institutional accreditation. One of the things that we did with this institutional accreditation is that if there's any place in the state of Georgia that wants to start a residency with our South Georgia Consortium, we're already an institution, and we could actually help those other areas start the residency. The gentleman earlier talked about the psych program in Savannah, and his first step was that he had to get institutional accreditation. Well, what we were able to do is to go ahead and set up a consortium of 5 hospitals right now, and it can add on to where we can already give you the institutional accreditation. And that's why this program we're talking about today is a little fast track compared to the other ones, because we already have the institutional accreditation in place. And when we set that model up years ago, we set it up so that we could add additional programs. A lot of good brains in the thoughts of that. Shortly after we got our institutional accreditation, which is the South Georgia Medical Education and Resource Consortium, we started a family practice residency, got that accreditation, and welcomed our first class in July. This is old history. You all have heard this before, so we'll real quickly go through it. And then last year we graduated our first class. That was a big time. Had a big shindig there, for lack of another word to say it. And what we're real proud to say is 66% of those doctors that we graduated actually stayed in Colquitt County and came to work for us. We were pleased to help the PCOM campus open up their campus there in Moultrie. We're their main hub for their residents that come here. I will point out that we also take MCG and Mercer and other medical students too. We're medical school neutral. We do have a bias towards PCOM because they're in our hometown, but we try to play ball with everybody. And then we decided why did we open up our family practice residency? Because there was a big need. And then we started thinking, well, we've got the family practice doctors now. What's our second biggest need? And it had to be psychiatry. I would almost argue that psychiatry is probably in a bigger need than the family medicine nowadays. So we became, this year we actually became a teaching hospital. Here's a picture of our first residence up on the top right. Down here at the bottom is one of our students. So a little bit at our hospital, we changed from a hospital to an actual teaching hospital. With that comes a lot of additional opportunities. Currently, we've got about 20 to 35 medical students. They're not from the Moultrie campus. They're actually from either the Swanee campus or other colleges. Rotations, they get to practice. If you have rotations in rural areas, it exposes medical students to practice. But without a residency program, you're kind of wasting your time. You've got to have places for these medical students to actually rotate. And once they do graduate out of medical school, that's the next thing they got to go through is a residency. And that's why we're here today. One of the other things that when y'all were down in Moultrie, we just got a notification that day that we got our nurse residency program. That was a pet project of one of ours. We do a lot of teaching at our hospital, but with our nursing students, and my daughter's a nursing student at Georgia Southern right now, is that they're not getting as much clinical experience. So we started this one-year residency program that allows the new grads, and they're all new grads, to actually spend a whole year not just actually going through the orientation, but they also get to go and learn additional clinical skills that they didn't learn while they were in school. The other nice thing that happened at the hospital is we actually established an IRB. And what is an IRB? An IRB is an by having an IRB, we'll actually be able to participate in some of those cancer drugs too. If you don't have an IRB, patients can come to your cancer center, but they can't get those experimental drugs that sometimes are ready to be accepted. So that's the phase that we did. We opened up an IRB, which really does open up an opportunity. Also, along with our PCOM and the hospital, we can do other research projects and get accreditations and hopefully publish some papers. What's been the impact on our community? Have you ever been to Moultrie in the summertime? I mean, not summertime, but wintertime on Thanksgiving. We actually light the courthouse up. It's worth the drive down there. Biggest thing I'll tell you, and you'll talk about physician shortages, having a medical school there actually has helped us attract physicians, because physicians lots of times want to come there where they can also teach. We also hire a half of a physician on our staff. For example, a pediatrician. We've got a pediatrician coming. They're going to be half-time with us and half-time with PCOM. So it really is going to help with some of those subspecialties that we're having a difficult time. Improves patient satisfactions. Our patients say that they've not got just one doctor when they come in. They have 3 or 4 or 5 doctors coming in taking care of them. So that's been nice. I know Governor Kemp has talked about a 2.5% or a certain price increase, but what does medical education have on the economy? I am the chairman of the Economic Development Authority, so we look at sales tax receipts. Well, if you look at this graph here, the top line is 2019 sales tax, sales taxes. The blue line is the last 4-year averages. So once we started, and these are real dollars, and I'll give you one of the months too. These are real dollars. Once we started this medical education track, we were able to increase the overall sales tax and income in our county. So for the month of August is when the medical school opened. We looked at September. So we got that in September, and it comes in August. We were $50,000 more in sales tax collections over the prior year and over the average. So you can save yourself so much through success, but this is one way by looking at medical physicians and looking at all the different programs. It is an economic stimulus to the economy to provide additional physician coverage and medical coverage. It's an industry by itself, medical field is. So I wanted to show that to you because I do know I'm coming here today asking for some support, but I'm showing you that the things that we do actually provides an economic stimulus. And most of those sales tax dollars actually go back to the state, not to the individual counties. I think we get maybe 3 or 4 cents of the whole 8. I'm not really sure. What is the impact on the new physician in the region? I know we had the MAG folks here earlier, but for every new physician you bring into the community, it's a $1.5 million impact there. It creates 5 direct jobs. And we weren't sure of the other number, and I heard somewhere around 14, but it does create additional indirect jobs in the market. So one of the ways to create additional economic stimulus, which we talk about that a lot in the EDA, is bringing in a new physician. Now, what I'm here for today, a rural psychiatric residency program. We won an award from HRSA, which is a federal agency that granted, they had 27 awards nationally. They give out $22 million. And Colquitt Regional Medical Center, we're real proud, was awarded $750,000 to start a rural psychiatric residency program. Now, let me tell you how crazy this is. We don't even do psych at our hospital. We don't have psychiatrists. We don't have any psych beds. But we saw the need, and we had the instruments with our consortium, and we said, let's do a psych program because the gentleman talked about earlier as far as some of the biggest needs that we have in psychiatry is that outpatient setting. So let's create that opportunity for a psych program. We are going to do a 10-bed psych unit to house some of them, but this is what it means when you're really looking at a hospital and what's their mission is to fulfill those needs of that community. So when I told my board, hey, we're going to do a psych residency program, they literally said, that's just crazy. Why? We don't have psychiatry here. Well, we do. And we're going to start it, and we were able to do it because we do have a psych hospital in town called Turning Point Hospital, which does psych and substance abuse. So we went over and met with them and talked to them about a residency program. And they agreed to partner with us. And that's where hospitals and communities start to work together and try to fix this problem, and we can. There is that program in Savannah, and I really am excited about that program in Savannah. But this will be one of 4 rural psych programs developing nationwide. Only 4 rural. Now that's sad. If you think about it, there's only 4 in the nation that are developing right now, and that's not going to fix our needs. We launched August. We got our grant, so we started in August, and it's a 3-year grant process. Why psych? Only rural psych program in Southeast. Rural. I did define that because I do know there's a psych program in Savannah. Only psychiatric residency program south of Macon. I always talk about, let's talk about what's happening south of Macon. I know there's legislators that live live north of Macon. But what I'm really interested in and what I want to fix is what's going on down in those rural areas. And these are solutions. The need is great. There's 2.3 million Georgians with mental illness. Georgia ranks in the top 11 states with the most prescription opioid deaths. 17% of the youth with suicidal thoughts and 7% attempt suicide. Here's a real bad and statistics that I think we're going to fix. 84 of the 159 counties in Georgia have no psychiatrist. Now, that's tough. Now let's go back over to talk about 2.3 million Georgians have mental illness, but we've got 84 of the 159 counties with no psychiatrists. Georgia ranks 47th out of 50 states nationally for access to mental health care. Compounded with the rural issues and disparities, rural behaviors, mental health is one of the top crises in Georgia. They talked about the jails earlier, the jail population like that. That's one of the things our hospital does. We provide the health care for our county and those mental health issues too, so that we can solve some of those problems. Logistics, it'll come under the consortium. The hospital will actually be the sponsor. It'll be a 4-year program, 3 residents per year. Turning Point will be our primary participating sites, and residents will rotate at outpatient clinics, having residents work in the region to see opportunities to practice. The good thing about how this works well with our program, with the Georgia South program, is that first year is called an intern year. So with the Georgia South program, we'll be able to fold those 3 psychiatrists into our first year intern year program, and then that's how it all just kind of works out, making sense. Here's our timeline. From the time we start, we'll actually have our first residents coming in July of 22. I will tell you that one of the things, and I know Chairman Parrish will say this, when we say we're going to do it, we always do it, and we are going to do this psych program. And I'm going to show you the numbers to where it's going to make sense, and it's actually going to be sustainable in the future. Anybody that tells you that a residency program is a loss, they're lying to you. Residency programs don't lose money. They don't. Startup costs you money, but residency programs actually should break even if they're run correctly, from the standpoint that you're seeing patients and you're paying faculty. You get what they call indirect and direct medical education. So residency programs are a win for all communities. We got the grant. It's pretty exciting. We were the only one in the state of Georgia to get this grant because of the need for it. So here's how we're going to spend our money, looking at the $250,000 that we got across for the next 3 years. Is it sustainable? And I'll also show you, and this is where I'll tell you that I do believe residency programs can break even. So if you look at year 1, 2, 3, 4, and 5, which is what they do, that's the total reimbursement that Turning Point will get. A lot of numbers, but just to show you that this is a sustainable program in the future. What I wouldn't want you to do is to invest funds in something that's going to flop. For our hospital, by being able to add the psych program, here's will be our fundings once the residency starts. As you can see, because they do rotate in and out, it's a 1.5. That's one of the problems with the cost caps, is that you only get the reimbursement per cost cap. The good thing about psych, and for those, and I know Ms. Cooper, you'll understand this, the cost caps sometimes limit you to the first 5 years. Well, with psychiatric, there's a rural psychiatric exclusion, which allows us to do a psych program which won't go towards our cost caps, because we've already started the family practice residency. So in theory, we shouldn't have been able to start another residency, but there is a rural psychiatric exception which allowed us to start our program. Here's our budget. I just want to show you. So if you look at the budget of starting this program up, we're going to start in 2022. These are real numbers here. First 3 years, 254, 292 lost the second year, and 254. What we're asking you for today, and we're going to do it whether you give it to us or not, is to give us that matching fund. We got the federal funds of $750,000, which is $250,000 a year. What we'd ask for is that you would give us $250,000 a year for the next 3 years to match that federal fund. Because remember what we're going to do. Go back to that sales tax slide. If we do this, we got to recruit a psychiatrist. We got to recruit other people. All those funds come back. If you look at just the impact this year on sales tax for Colquitt County this year, over $500,000 in additional sales tax collections. not counting the state income tax that those doctors have to pay. Return on investment. I really believe psychiatric does have a return on investment, reduces hospitalization, reduces homelessness, chronic health issues, reduce crime, reduce drug abuse and overdose. The nice thing about our program is going to be a dual program. It's going to be psych and substance abuse, and that's why we're working with Turning Point. So we're not just focusing on a single diagnosis. If you know anything about psych, lots of times most of your psych patients are dual diagnosed. They have psych and substance abuse issues, and that's why we chose, it's a natural partnership to partner with Turning Point, which is mainly a substance abuse center. I get excited when I talk about this. We have a proven track record, folks. Since last 7 years, our hospital has doubled in its capacity. We've added over 500 new healthcare jobs in Colquitt County. We helped bring a medical school to the region. It says we brought it, so Brian, I'm sorry. We actually helped bring it. We established a family medicine residency program. We got the grant money for the psych program. And here's another thing. When we got there, we didn't have nurses. And Georgia Southern did a study for us, and we looked at 66% of our workforce was going to be retiring in the next 8 years. So we went to Southern Regional Technical School, and we went to ABAC and helped them start another RN program so that we can actually start it. We fund it, we teach it, we help provide clinical faculty for them. A lot of people come to you about the issues. But one of the things that the previous CEO said, Jim Lowry said one time, when people come to me with issues, I want them to give me the solution. So I'm giving you the solution. This is our solution. We had a nursing crisis. We go out and start a nursing program. We had a physician shortage. We had patients that literally were waiting 6 months to get new patients. So we started a family medicine residency program. We've got a psych program. We've got a lot of the state hospitals closed down. We've got people that need psychiatric care. So I'm giving you the solutions too. Here's my vision. And if anybody knows anything about me, I'm a visionary. I'm always thinking about where we're going as it. So my vision for Colquitt Regional is to be the regional provider of rural medical education. And that's what I want to do. I really do. I like to tell you where I'm going with this. And where we're going down the road is we're doing family medicine. I want to do psychiatry. I want to do physician assistants and nurse practitioners. We're doing nurses. We want to be a training site for EMTs because that's a big one. Physical therapists, we already. Pharmacists, we need to do that more. And any other opportunities that we have to provide that regional education. Because there's not availability. I mean, I think our academic institutions around us have done a wonderful job at teaching the didactics, teaching the book stuff. But when those people graduate, we've got to teach the additional hands-on things, and that's where we come in. So before a nurse starts, when a nurse graduates, when my daughter graduates, we've spent another 12 weeks actually training them. So wouldn't it be nice if we could train them before they actually start taking care of patients? So that's the vision. I wanted to give you where I'm going because I'm probably going to come back with something new next year or two. Thank you. And I do want to say, and I know every one of you, most of y'all in the room, I've been in your office, and I want to say we could not have done this without your support. And I really mean that. I come to you a lot. Well, not a lot, some. I don't ask for a lot. The original 300,000 really grew a lot. I'm asking for 250, but we'll use it or I'll give it back to you. Any questions?
Thank you, Jim. And before I turn it over for questions, I just want to thank you, just for being innovative and coming with solutions, because as you said, we've heard about a lot of problems over the last 3 years, and it's good to hear a solution that's not really going to cost us a whole lot in the big picture. So thank you for what you're doing down there to help the region. So questions? Representative Taylor.
Chairman. I want to offer, similar to what Sam had to say, you're making a difference in our region. You are thinking outside the box, and again, you came with solutions, and that's one of the things we need. Healthcare is so vital. It is an economic engine. I have seen communities just die away because they lost their health care. And you're making it a growing entity. It's part of a whole community. And it is really greatly appreciated. And the thinking out of the box, solving problems for us and identifying where we can go forward. And it's very much appreciated. Thank you.
Thanks, Representative Taylor.
Chairman Powell.
Think with me for a minute, Jim. The part of what we're trying to do is to resolve healthcare issues in rural Georgia, and really like what you've done at Colquitt Regional and working with Tift, Archibald, Phoebe, Colquitt, South Georgia Medical. But all of those are public hospitals. If we wanted to replicate this in other areas of the state, how would we basically package what you've done? And I mean, because some of it's been done by fits and starts. It started primarily in Albany and then ultimately centered in Moultrie. But knowing what you know now, if you were to start all over again in another part of the state, it wouldn't take you as many years to do it. But how would you package it so that we could replicate this in other parts of the state?
You know, I had that question earlier, and I think I know the answer, is I would have thought bigger. Because we started out with the original 5 hospitals, and I think that's limiting. But it certainly fixed my backyard. It really did. But the vision, I was telling this to Jessica Ribach today, who really is the mind behind what I do. She gives me all the good ideas and stuff, is I would have made the consortium more of a state thing. And I think that's the next step for the consortium is to, and I heard from the gentleman there in Savannah, where he talked about how he had to wait a year to get the institutional accreditation. I probably would have started that, if he would have called me, I'd have said, yeah, come on, we'll work with you. So I would have probably done it bigger. I would have, but I didn't know. I mean, this is my first time ever doing graduate medical education. So I would have probably thought it a little bigger.
So I guess my question is, if we wanted to replicate this in other parts of the state, would it be better to do regional graduate medical education in different parts of the state? Or would it be to take the framework that you've got and expand it into the rest of the state?
If you want a short-term quick fix, I'd probably call, and I'm the chairman of the consortium, and I'll go ahead and tell you, we'll do it. Now, I got to bring my partners along, but I do a rural track because the gentleman that started the psych program is a 6666. That's and you're going to have a lot of more numbers. So it's really based upon the number of people of population. There's a lot of exceptions to rural track programs. When we started our residency program, we were a rural track program. So we actually connected with Phoebe, and we were kind of a branch, for lack of another word, of Phoebe. So now that we're bigger, we actually have our own. We're no longer the rural track on the family medicine program. So I would probably just do it smaller. I would probably do it smaller and maybe connect them with us or connect them with an existing program. So if, for example, if you're doing a program in Waycross, I'd probably connect with the Savannah program, because you can, the bigger programs like, and I don't want to speak for that gentleman because he did a wonderful job talking it. So a bigger program can have a rural track underneath it. So that's one way of doing it. So if you've got a bigger program, now I'll tell you, the big guys don't necessarily want to talk to us small guys. But if you can take a program like in Warner Robins, or if you take a program, other residency programs, they can have tracks off of that real quickly. Or we'll offer to help anybody you want. Basically what we do is we just charge you the cost.
So from the standpoint of the state, if it wanted to encourage graduate medical residency programs in rural parts of the state so that then that encourages those folks to locate in rural Georgia. Then we need to incentivize or mandate or whatever it is for the bigger programs to have rural tracks.
I think that's one solution, but the first start would be, say, start taking on, if you're really serious about it and your medical staff's serious about it, start taking medical students and see if your staff is ready to do that. Because you got to have your medical staff on board to do this. So the first kind of up or down is whether they'll take 5 medical students, if they'll just take 3 medical students. And if you start to, and you can do residencies, Jessica, what's the lowest population you can do a residency?
Based on your hospital volume, family med and internal med are the 2 that primary care that you can do.
So you could do a family medicine program in most places, but the first start would say, start taking medical students, and then they could probably get a program, if they're really serious, if their medical staff is serious, they could get a program up in 2 to 3 years, I think. What do you think, Jessica? In my world, it's probably 2 to 3 years. Other people's world, it might be 3 or 4. But we'll help them. So if you wanted to do it, one of the best things you could do, and you've already done this because you're starting to incentivize people to take medical students. If they're really serious about growing it, start with the medical students. Because, and I was talking to Steve Gontney at Chris Regional the other day, I said, Steve, start taking those medical students first, and then you get the interest in teaching. That's how you start to grow it. But if you don't take the medical students, the doctors most likely aren't going to teach your residents either.
Chairman Parrish. Jim, thank you. Good presentation with a lot of good information. Got a couple of questions for you. Under your residency program, will you be required to use the match?
Yes.
Why?
That's out of my pay grade there. Jessica, why do we have to use the match? Because it's ACGME accredited, is that right?
We can participate with the medical schools, but they changed the rules for the National Residency Match Program. You just can't negotiate outside of the match unless you're working with the medical school, like the 3+3 programs that they have.
But I know where you're going from. I know where you come from. And the way we do it, because we take a lot of Georgia residents, because I think if you're going to invest your money, you want somebody to stay in Georgia, is that we weight the applicant. We give them additional weight for being a Georgia resident. So a lot of people say, well, we can't really select Georgia over Alabama. You really can just by giving the weight, higher weight to the Georgia residents.
Well, that's one of my questions, and if a Georgia medical school graduate application has more weight than an applicant from wherever, then chances are that person would get in the program, and then we all know where you do your training, you're more likely to stay. Okay, that's good. And then I think I heard, and you said, I believe, that you'll be able to draw the federal match on this because it's a new program, is that right?
Right, so the caps, it's a separate set of caps for psych.
All right, are you capped out now with these numbers, or is there room to increase that without going over the cap, or what?
On the psych, it'll be a new one, but within 5 years, and we're in year 4, we do cap out. Okay. And that's where we're hoping that the federal folks will actually eliminate those caps for the rural track programs. Jessica, are they still capping out?
A rural hospital is under different CMS rules, so you don't cap out if you start a new program with a new program director and new resident.
Within that 5 years, you could add to this, right?
Yeah.
And not exceed your cap, so therefore you'd still get the federal match dollar.
Right.
Okay. And then I think I heard you say
now,
that.
I'm qualifying that. That's the brains back there, so I'm.
Well, we'll have some more conversation about that. But I think I heard you say that you don't believe that a residency program will cost you once you get it going.
I don't believe you should lose money on it.
Yeah. Okay. Thank you.
And I'm an entrepreneur. I'll just tell you that. You know, I look at my residency program, and I like what the gentleman said, in order for me to break even in the residency, they got to see 1,000 patients a month. So I look at the residency program and say, folks, you got to see 1,000 patients a month because I bill Medicare and I bill Medicaid, I bill the other ones. So that's, you just look at your costs, divide it by the average reimbursement per visit, and determine how many visits you got to have this month. I'm a little different, and most of our doctors understand that, Matt. No pushback.
That sounds like farming, Jim. Just break even. That's all we want to do.
Got to do.
Yep. Anybody else? Patty?
Thank you, Mr. Chairman, and thank you for your presentation. Enjoyed our visit down in Moultrie a few weeks back. It was beautiful down there. Look forward to coming back. But this is good information that's been discussed, but I'm thinking more about what I'm dealing with right now with my husband's situation, being with a spinal cord injury. Thank God we have the Shepherd Center here in Georgia.
Amen.
And I ask you for your prayers that when we return to the Shepherd next week, that they're going to give him the okay to return to that aggressive therapy that they have. But once we are finished with that therapy, they call it the day program, and they provide housing for us to stay there at Shepherd. But once he's done with the day program, there's another level of therapy called beyond therapy. And that's at Shepherd, of course, but there's no housing for that. And we live way down in rural Georgia. So
Where do you live?
In Taylor County. Mm-hmm. And so I'm just curious to know how are you handling situations that you may occur from people in Colquitt County that may have spinal cord injuries or...
I can just give an example of a patient that
Sure.
went to the Shepherd Center. We do this quite frequently because we've got the Vereen Center, which actually teaches physical therapy. So when we have a patient, because it's very expensive to live up there at the Shepherd Center, but I'm going to tell you, they do a great job, so on record as saying they're excellent. We send our therapist up to the Shepherd Center, and they'll let you and train our therapist on the therapy that patient needs. And we do it at our own cost because that's what we should do. It's our community. And they'll spend some time. We've had, and I don't want to give the patient's name, but it was a popular patient. So we actually sent our physical therapist and occupational therapist up there. And I think they stayed the better part of a week to actually go through all those therapies. So when they came back, we were able to provide transportation and come to our rehabilitation center to where they could get that same therapy from home. So, and your hospital should do it or would do it, but sometimes you got to call. And with those type of situations, typically somebody will call me and say, hey, my loved one's coming back from the Shepherd Center and I want to keep it going. And I said, well, hey, I'm glad you told me quick enough, and we'll just send the therapist over. That's what they will do. I think your hospital would do that. I mean, we would do it every day. Okay. That or move to Moultrie. Yeah.
Wait a minute.
Joking.
Thank you.
Yeah.
Well, thank you. That's good information.
Good deal. Anybody else? All right. Well, just to kind of sum it up, just so I'm fully understand, you were requesting a $250,000 grant for 3 years.
Yeah. I sent most of y'all letters, but this is why. And I would say the biggest thing is that what this whole thing has been about, physician shortage, and we're trying to come up with that solution.
Good deal. Well, appreciate you being here today. Appreciate you being innovative, and thank you for what you're doing down there.
Do want to give Jessica Riverbuck back there. She's our president of our Southwest
Jessica,
Georgia
you want to stand up just so everybody knows what you look like if they have questions afterwards?
I will tell you, she's the head of all of our medical education, and a lot of these things, she does all the legwork and stuff, and she's got the vision too, so I do appreciate all she's doing.
All right, hold up. Chairman Cooper's got something for her.
I'm sorry. I want to thank you for also, trying to meet the needs of your community. But you seem to recognize also that it's not just turning out more physicians or more nurses, that what we need is quality. I mean, we owe the students, and is required by these residency programs or these medical programs, that they meet a certain high standard, and that you realize that, and that you realize when the nurses are not getting what they need in their education programs, that you're willing to step forward and try to, make up for that need. Because it's not just numbers. it's the patient in the end, and we have to turn out quality physicians and nurses and everybody that are well-trained and know what they're doing to take care of these patients. And so I appreciate the fact that you are interested in that, not just covering what your hospital or your community needs, but both areas.
I'll give you a secret. My daughter's in a nursing program, and I watched her the last 4 years, and that's how the residency program got designed, because I realized she's going to come out and say, being responsible for somebody's life. Those nurses need that training. They really do.
Well, and you hit upon it. It's one of the things and reasons why so many of our younger nurses leave nursing is that when they don't get an adequate education, as soon as something happens and they almost make a mistake, or they make a mistake where somebody's life could be put in danger, they will leave hospital nursing as soon as possible. They'll go to a doctor's office. They'll go somewhere else that they're not put in that kind of situation, or they'll leave nursing altogether.
You're absolutely correct.
Thank you. But thank you for looking for quality for patients, too.
We got our 11th A, and I will tell you, our first class of our residents that we graduated, all 3 of them, the first class that we started, passed their boards right out of the gate, so it was exciting.
Good deal. Thank you, Jim. Appreciate it. Just a few housekeeping things for the committee before we finish up today. We'll be in Americus, Sumter County, next month, December 17th and 18th, for our final wrap-up. So I encourage everybody, as you kind of ride home today and ride to Sumter County next month, be thinking of ideas and more solutions to add to the mix, because that's where we're going to kind of wrap things up and try to put stuff on paper and get stuff ready to go for session. So appreciate everybody being here. If you want to take your stuffs, as we have been doing at the other meetings, anything you want to take out of your notebook, I think Holly's got some folders. If you want to take anything home with you. Also, lunch will be provided, I think that way. That way? That way. Okay. But if you need a drink, please grab it from the kitchen before you go, because all the drinks are still over here, but the food will be over there. Am I missing anything, Chairman?
We're good.
All right. Thank you all for being here. Safe travels.